Good afternoon, and welcome. As you're joining in, I invite you to take a moment to settle in. If you're able, please share in the chat your name, where you're listening in from, and your organization. And if you feel comfortable, you're also welcome to share your contact information. Welcome in, welcome in. We'll take a moment to allow everyone to arrive. All right, good afternoon again. Please share your name in the chat, where you're listening in from. And if you're comfortable, please share your contact information, including your email, so we can stay connected beyond today. All right, my name is Akinya Doyo. It is truly a pleasure to welcome you on behalf of Medical Bridges to our World Health Day Global Health Forum. Today, we are holding space for a 4-hour conversation that brings together voices from across the global health system. Leaders, practitioners, and partners working to expand access to care and strengthen health systems in meaningful ways. At Medical Bridges, our work is rooted in connection, bridging surplus and need, but more importantly, bridging people, knowledge, and possibility across borders. We've learned that real progress happens through collaboration and shared understanding. On a personal note, I'm reminded of a Dholuo saying, Atonga mayot, iyombo koth. This loosely translates to, it is a light basket with which one can run and escape the rain. A basket becomes light not because what it carries is small, but because of how it's carried. When hands come together, the weight shifts. When ideas are exchanged, the burden becomes shared. And when knowledge moves freely between us, what once felt heavy begins to feel possible. And that is what today represents. The work of global health is not light, but collaboration makes it lighter. We're especially grateful for the support of the World Affairs Council in helping bring this conversation to life. And we're particularly grateful to have Ronan O'Malley from the World Affairs Council supporting us today by helping guide and surface questions through the Q&A. Before we begin, just a few quick housekeeping notes. Please remain muted unless you're speaking. Feel free to engage in the chat and share reflections throughout. If you have questions, please use the Q&A feature located at the bottom of your Zoom screen. Our team, along with Ronan, will be monitoring and bringing the questions into the conversation. We will take a short break after the second panel. All of our speakers are distinguished leaders, and their profiles can be found on our website in the World Health Day event page. Today's conversation is centered on shared learning, practical insights, and the collective work of improving health outcomes across communities. This is a space for thoughtful dialogue where we explore global health challenges and consider how together we can make a meaningful difference. It is now my honor to introduce our event chair, Sonali Korte. Sonali is a visiting fellow at the Baker Institute for Public Policy, a leading research institution that brings together experts to inform policy and advance thoughtful, nonpartisan solutions to global challenges. She brings decades of leadership experience, including serving as the head of the USAID Bureau for the Humanitarian Assistance, overseeing global disaster response efforts, and playing key roles in addressing major health crises such as Ebola, MERS, and Zika. What stands out in her work is her ability to see the full picture, how different stakeholders across sectors and spaces come together in ways that make real impact possible. She also serves as an adjunct clinical instructor at the Baylor College of Medicine, mentoring future global health leaders. We're honored to have her guiding conversations today. Sonali, thank you so much for your leadership. I'll now turn it over to you.
Thank you so much, Akini, for that beautiful introduction to the event and to me. I'm not sure I deserve it, but thank you anyway. Let me just start by thanking you and Walter Ulrich, CEO of Medical Bridges, for hosting this event and allowing me to participate. It really is an honor to be here with you all. And I'm going to keep my opening remarks very short as I want to give our speakers and our panelists and our audience maximum amount of time to engage. But let me just start by framing the conversation. In 2025, the world experienced major declines in global health funding from the United States and a significant reprioritization of focus through the budget process and also the new America First Global Health Strategy, which prioritizes HIV/AIDS and pandemic preparedness, however, deprioritizes some other areas such as maternal child health and vaccines that the US had traditionally been investing in. Yes, the last year created shockwaves around the world, yet at the same time, there are multilateral institutions in the world, Global Fund, Gavi, and others are providing stability to funding. There are INGOs, governments, and individuals that are stepping up to the plate and meeting the moment with a lot of ingenuity and creativity. And there are important lessons to be learned from the past that should be remembered now, but can also shape the future. And these are the themes we want to focus on today. And so with that, I am going to move on and introduce our first speaker or speakers. And so let me start by introducing Major General Dusty Schultz. Major General Schultz is a retired distinguished senior military leader known for her expertise in Army cyber intelligence and space operations across the US and Latin America. Throughout her career, she's been entrusted with high-impact roles supporting the Department of Defense, shaping multinational strategies, and strengthening international partnerships. She's a trusted diplomat and a strategic thinker. Her leadership from crisis response in Puerto Rico to intelligence modernization at U.S. Southern Command has earned her the recognition at the highest levels. I think it's very appropriate that we start off broad, and I think in the vein that Akini said, in terms of building connections and looking outward, we're so thrilled to have Dusty's expertise. And to kick it off, we're going to have my good friend and co-partner, Walter Ulrich, our CEO, moderate a conversation with Dusty. So I'm going to send it over to you, Walter, to take it away. Thank you.
Well, thank you so much, Sonali, and thank you for your leadership on this event today. What a privilege it is to be with Major General Dusty Schultz. It's a real joy, privilege to have you to kind of help lay the foundation for and the context for the rest of this very vitally important afternoon. Let's start with the big picture. You know, all your military career, you've seen the world, you've been in many countries. How would you assess where the world in general is today?
Walter, thank you. Thank you, Sonali. Thank you for Medical Bridges, because truly, for me, that is the #1 form of diplomacy, care, for our world population. And I think it's really special to be here today. Yes, as you alluded to, big picture, we're in a very interesting place in our world today. Um, those that don't learn from history are doomed to repeat it sometimes. And the place that we're in today is we have numerous crises, and we have remarkable medical capacities, and yet we're not meeting all the needs that we can and should worldwide. So this conversation to me is absolutely vital. I was never so touched as when Admiral Stavridis had me work with the Continuing Promise Comfort Ship mission throughout Latin America. And we worked with NGOs and PBOs, and I got to see the power of what people with focus, desire, and drive to make the world a better place could do. And we're in a place to really need to extend that. Um, I I would like to think that we're in a place that where medical communities can unify people to drive them for goodness and to heal in so many different ways. And so, having been in everything from combat to partner nations who just don't have the services that you can find in the United States or in other places in the world, the question is how do we help bridge that? How do we fix that? When we look over at what has recently happened in whether it be Venezuela or Iraq or the Middle East, we should be very concerned for the populations that are there and think about the ways that we can help serve and provide to those communities.
You know, you and certainly Sonali and Kenny and I, we understand how desperate it is. I'm not sure before I joined Medical Bridges 7 years ago that I fully understood it. How might you describe that level of desperation in countries like Sudan and Haiti and maybe countries at war?
Yeah, so I'll start with Haiti because that was probably one of the um, deepest times that I really saw um, incredible need at its finest. It was when you see mothers making mud cakes to feed to their children because that's the only nutrients that they can provide to them at the time. That's that is at new levels just daunting. When you see the countryside become a moonscape and yet you're smelling the burning of rubber because that's the only fuel that they have to make food or heat their homes with. That's huge. Uh, and so we take so many things for granted. I will tell you that even when I was in Puerto Rico years later, uh, and after the hurricanes, so many people, we forget, we get a little spoiled and we don't realize that, well, if we have the power off for 12 hours, that's a big deal. Well, power being on in Haiti is a huge deal. We took power for granted in Puerto Rico. It was another island nation. But we have a little bit of blinders on as a Western world when we think about power, fuel, and food security, let alone medical security. I mean, right now, if most people that are reside in the United States or in Europe, if they have an issue, they know that they can get to a doctor or immediate care in a very short amount of time. You have to rethink your calculus and what you're doing when it's going to take you 10 to 12 hours to get to just to the medical facility or get the support that you need. When we deal in foreign countries that have been war ridden, um, you know, it's not camping for a day with all your niceties next to you. It's it's living in a have not surrounded area with minimal food, minimal power, and great uncertainty. And it really it is a fight for survival. And so that's something that in our world we have to remember, and in my opinion, be empathetic towards those that are in those situations, because they are not fighting to build a 401k or anything of that. They're fighting for dinner. They're fighting for warmth. They're fighting for food. They're fighting for basic medicine and needs. And we can be a little bit spoiled when we think about it that way. And we have to pause and think, okay, on your worst day, what have you needed? And I will tell you, normally on your worst day, one of the biggest challenges is just to get something as simple as clean water.
I, you know, today is World Health Day, which is obviously why we're doing this event today. But on this day in in this day in 1994 was when the Rwanda genocide took place, and 800,000 people, Tutsis, were killed at that time. And you would think that some of the lessons from that violence we would learn, but I've heard one statistic that there are 61 countries that are either at war or having a civil war or similar violence. Does, how can we be helpful to countries in that kind of a situation?
Well, I believe that as we look at nations in those situations and their neighbors, is finding the right partners that you can trust, that want to provide capability like water, like food, like medical services, that are not bargaining it or being succumbed to transnational criminal organizations who are manipulating a market or manipulating people. So figuring that out is not easy. Figuring out the right organizations is a critical element. I will tell you, when I was dealing with Haiti, there was several NGOs that were fundamental to really making sure that we were able to point people in a direction that they could trust and know that the goods that were being provided and supported were really critical and were getting to the people.
You mentioned earlier when we were talking that after the 2010 devastating earthquake, which really started the downward spiral for Haiti, that you, and as a member of the military, managed to get water to people who otherwise didn't have water.
Well, and it's interesting that you say that, Walter, because or bring that back up, because I was really shocked as a military member. Um, that incident was being handled by one of our government agencies, and Southern Command was supporting it, and that government agency said, "Hey, we've got this covered. We're going to get them water." And the question is well, when? And well, we'll get it there in 3 weeks. When it was ended up being is sharing the opportunity for Pepsi to collaborate with FedEx to then bring the goods to the ground. And I think it was Food for the Poor and another NGO that received the goods and distributed it to the population. And it was more about finding a way where people could unify and collaborate, and less of my hand as a military member and more of just allowing them to have that forum and to keep the communication flowing. And I think that's really critical. Is a lot of times we want to stifle communication because we want to control a narrative or something, but the reality is for us in the military, it was making sure that those avenues were open and that people were able to talk and understand what was going on so we could get that water on the ground to the people that needed it.
Well, all of us at Medical Bridges have a great respect for Southern Command, which of course you were part of for quite a while as well. So thank you for that small part of wonderful national service and now what you're doing today. You know, you and I agree about the moral necessity to do unto those who are the least of our brethren. But in the opening, Sonali mentioned something about, the inward look. Is there any other reason other than being good citizens of the world to provide succor and support to the most poor of the nations?
Well, okay, I go back to a rising tide lifts all boats, and I would say that yes, goodness to the world, but the reality is that as we help our world population, we're an ecosystem. And so anybody that thinks that they're alone out there, they have neglected to realize that we are a world ecosystem that is interdependent. And so having other people and countries not starve or not suffer from plagues or disease or lack any other kind of things, it's as we can bring the quality of life for everyone up, that enables everyone to thrive and then make better choices and get stable governments and stable cultures to really make headway for those sovereign nations. But as when people are just fighting for their next meal, perspectives change. And so really helping others to establish that is critical and fundamental in my opinion.
When developing nations thrive, it creates an economy that people all around the world can be more successful. For us in the United States, and I know there are people on this call from other countries, but for those of us in North America, when the world is thriving, that opens markets for us. It opens investment opportunities. It enables governments then to be run in an economically sensible way with their citizenry. And I think the U.S. maybe gets more benefit from when we are able to do something helpful than the benefits we actually give. Now turning to the World Affairs Council first for a minute. Let's see, Ronan, have you had a chance to tune in on us, and do you have any questions for us? Or should I just keep pushing forward? I think I'll push forward.
Yeah, if you want to push forward, Walter.
There you are.
We don't have any questions yet, but as soon as we get some, I'll let you know.
Hey, you're a smart guy, Ronan. What question would you ask?
Oh gosh, I suppose, well, first of all, Walter, thank you and all of your colleagues for the incredible work you all do. I'm always impressed and kind of inspired by what you do, despite the kind of awful headlines of the last number of years, whatever corner of the world might be. And General Schultz, thank you, so much for your service. You mentioned Southern Command. Admiral Severides is someone we've hosted 2 or 3 times. I think it's amazing how much sometimes we forget the corners of the world that are closest to us. Like you said, everyone I know who has been in Haiti said it was just absolutely catastrophic and hard to believe the level of suffering and damage. Maybe just on a positive note, could you maybe give us some examples of the places where you have served in uniform, where the U.S. military has been used as a soft power instrument, and maybe the kind of the beneficial aspect of that might take months or years to kind of reflect later, but in some ways it's the quiet, but in some ways kind of more moving ways in which we can have a long-term impact.
Well, in that regard, and thanks, Ronan, absolutely. And I will tell you, for me, I think Admiral Sirtis spread some seeds in as a young officer's mind. So when I came back as the director of intelligence and worked again in Latin America, working with partners in their language, meeting them where they were at, not having a preconceived notion of how things should be, but met them where they were at, listened to them, and then collaborated, treating them as, partners versus my being, a know-it-all that just says, hey, this is how it's done. Because I think that's where we go wrong, is when we think we know a situation and we really don't. And we don't know the nuances. I will tell you that even in Puerto Rico after Hurricanes Irma and Maria, when I explained things to my soldiers and let them go after solving a problem, they came back with better solutions than I could have dreamed of and engineered. So when I did that in Latin America, whether it be in Peru, Argentina, Brazil, Panama, Colombia, I mean, we had phenomenal partners. The Dominican Republic was able to really listen to us about challenges and then create solutions, also understanding that the way we did things didn't necessarily work for them. And I actually akin it to a power cord. Because if you go with a power cord that you would plug into the wall in the United States, and you even go to Europe, it's not plugging in. And so you have to understand that you still need power, but it might come in a different form. And that's okay. And sometimes we got to go the old-fashioned way and use a flashlight or a lantern. And so appreciating that people are striving and working with the resources that they have to make those fundamental changes absolutely critical. When I was in Costa Rica, hearing the leaders of a country recognize their problem set, but also trying to understand how to meet their people, their populations where they were at. Sometimes we get caught up in thinking about something from a city perspective, and you might be dealing with an agrarian economy and an agrarian community. That's very different. I'm a farm girl by nature, so I can really talk to that all day long. But it is very different than when you talk, things from a different perspective. And so that's where I talk about we have to meet people where they're at. Respect that they are intelligent and capable, and really make sure that we're driving towards unified values, and then collaborate with them. Now, I would also say that there's a magic too that I feel like was really helpful when I was dealing with Latin America, was working in language. Um, I know many of individuals in the world community speak English or parle français, but when you speak in a person's native tongue, I think that's also you can tease out a lot more solutions, because people are really speaking their first language in a language that they understand and really want to drive. Hopefully that answers a little bit of what you were getting after.
As you talk about it, what I keep hearing over and over and over again is respect for the people that you're trying to help, respect for their culture, respect for their way of life, even if some of their customs may be different than our customs. How do those differences complicate things, and how do you overcome those differences?
Well, I think those things complicate it when you come at it with a bit of hubris. It's going to be hard for you. When you think you have the solution to everything, then you're going to realize quite quickly that you don't. It complicates it because you have to sometimes slow down and listen. There's a saying in the military: slow is smooth and smooth is fast. So if you slow down and use, the Japanese saying of you have two ears and one mouth, so listen twice as much. Slow down and listen and really hear what's going on, and be able to have that communication back with your partners. Then you often get partners that are on fire, that really think that you're not there to wag a finger at them. You're there to be a partner. And I think that is absolutely critical.
As I've been listening to you, I hear several lessons learned. One obviously is go slow, be smooth. Another one is respect the culture, don't have hubris. The interesting idea that's true throughout such a large part of the world, the electrical plugs don't work the same, right? And I also heard you have a leadership hint in there that rely on your colleagues, the people who are on the ground, the people who might work for you. And in your case, they may be several or many grades below you, and listen to them. Are there any other lessons learned from your breadth of experience?
Well, and it's interesting that you say that, Walter, is because a lot of times too, going back to the Hubers piece, I'll just use this quick story from Puerto Rico. So there I was in Puerto Rico, and no water, no power. We were cutting down trees just to get to the key waterways to purify the water. And I had one of my soldiers who was a specialist. So, and a specialist isn't a very high rank. Um, and he was doing a phenomenal job analyzing the water for purification that was purified to be able to then distribute it. And I came to find out that that specialist was actually a medical doctor in Puerto Rico. Yes. And I looked at him, I said, why aren't you an officer? And he said, well, while I was going to school, I didn't have time to go to officer candidate school. So I joined after, and I didn't want to go and do more medical stuff. I wanted to learn something new. So I went ahead and did this. And so, and while it's symbolic because he actually had a medical degree, there are people that have the equivalent of life degrees of being a medical doctor who are doing something. And how do you respect them? How do you show them dignity and respect, and really that you're going to listen to them? And sometimes also that listening does not mean you're going to do what they want you to do, but how do you have a way that you are able to communicate and share the critical things that need to be done? Because that's the other thing too, is I'll tell you, when I was in Puerto Rico, one of the most shocking things to me was when um, I was told the surgeon, um, the Secretary of Health for Puerto Rico wanted to see me, and he walks in my office, and I come to find out that he was also one of my Army Reserve colonels who was a neurosurgeon who didn't take a salary from Puerto Rico. And he was bold, and he said, Puerto Rico needs you, and you have this capacity. I know you do. Can we please use it? And he was extremely bold. And I said, well, we're not the National Guard, so we need 1, 2, and 3. We need these things to make that happen. And he literally got on the phone. And then next thing I knew, I was talking to the governor of Puerto Rico. But helping people that hear that their voice has power and they should use it, that is also really critical. And so in that regard, I feel very fortunate to be around people who are dynamic, they're thinkers, and they don't have to be all thinking the same way, but they know when to use their voice. And also, there are times that we have to pause and just listen. Listen to those around us, because we're not always going to think the same way.
The issues of dealing with foreign governments, when you're in the military and you're representing the United States military, you have more clout in dealing with foreign governments, though it's never perfect, I'm sure. For a lot of NGOs, and some are very, very large, and a couple of them are represented on this call. Some are more medium-sized or small, like a Medical Bridges, or how do we work through the bureaucracy? Do you have any suggestions on how we work through the bureaucracy of countries that are suspicious, even of organizations that are really trying to help, through the bureaucracy and the governments?
Yeah, so first of all, I would say that I've dealt with that my whole career. I mean, as a woman in the military, um, I had guys that were suspicious of my capability as a young female officer that was driven and wasn't going to take no for an answer. One of it is don't take no for an answer. I mean, really, but it's really about building trust. And so getting to know people on a personal level as you can is critical, because people need to know that you are what you represent and you're going to consistently provide what you're saying. And so having that bond of trust to me is fundamental. And people when I was a young officer, would look over at me, and after they, you don't need to rush to failure. You need to just be persistent and consistent with what you're doing.
You know, I'm going to share a quick story myself as you say that. A few years ago, one of the countries we served with a very dear NGO that has major headquarters in the US and works in many countries, Pakistan and many other countries. One of the countries changed their regulations and we no longer could get in-kind medical supplies into the country. So the woman who headed in-kind deliveries around the world asked me if I would go to Pakistan and meet with some very high-level officials in both province governments and the national government. And I kind of said, why? I don't speak the language, I'm not, your organization has done so much in which Medical Bridges has just played a relatively small niche. And she kind of twisted my arm, and I actually had an absolutely delightful trip to this country. But I began to realize the first meeting we had with a high-level government official, they would, they would bring me into the room, right? The, 6'2" American head of this nonprofit, right? And they greet me with all this, and of course she would be kind of standing beside me, and then I do the few introductory remarks, and then she would take over. And I realized that what I really was I was the token to get the meeting because I was a guy, right? And in fact, in many cases, the meeting would slip into their native language, which was absolutely fine for me. And I was so comfortable when I realized that, yeah, I'm not the smartest guy in the room by any chance. This woman was smarter than I was, but that if that was the role I could play to make that difference, I was delighted to play that kind of a role. And, as a young woman officer, I'm sure you saw lots of that.
Absolutely, Walter. But at the same token, I will say that as time went on and people knew when I walked in a room, after they started like parting the ways and they're like, oh no. But it's once again that's that consistency of knowing that, you know, the people that you're dealing with are relentless and focused and going to provide. And they're not going to be a fair weather friend. They're going to be, in good times and bad times. Because my mother used to always say, when the going gets tough, the tough get going. And you really know who the people that you want to be around is on your worst day and your worst moment. Are they there? Or did they just fade into the background and not? So,
We talked already about Haiti. Are there other countries, which one or two or three other countries might you most be concerned about right now in terms of both their ability to grow and ultimately survive and flourish, but also their health situation?
so the answer is yes. I think that our global stability in the health arena is a little bit at risk overall right now. I would equally tell you that I personally get a little bit more concerned with authoritarian regimes where medical communities are restricted to only what they're mandated and not allowing to thrive as they recognize needs and skills and they grow in that regard. I will tell you that you can go something as simple, yes, as Haiti, because Haiti is a stone's throw from the United States, and at the same token, it has deteriorated so rapidly. But yes, what's going on in the world right now in the Middle East is extremely concerning. I would also say that everything I look at our Ukrainian counterparts and think of it's impressive of what they've done, that what Ukraine has done, and what they've lost. They've lost about 500,000 people, but that being said, the Russians have lost 1 million. So that's daunting and hard to digest. I would be fundamentally concerned with any country right now that does not have easy access to medical care. And I think if we called out one or two um, in the Southern Hemisphere or anything of that nature, I think I would be unfair because there are many. And I would say the focus, whether, yes, we want to help rebuild the oil capacity in Venezuela, and Venezuela has needs, but so does Cuba, and so then we can look over at so many other cascading countries that have had failed governments. I would look at countries that have failed governments or ones that are completely ridden by transnational criminal organizations, because medicine is then almost taken as an additional way to manipulate the society and control people.
That's so tragic. It really is. I'm going to turn it over for a minute to Ronan. I think we have one more question from your end, Ronan, and then I'm going to have a follow-up question. So go ahead, Ronan.
Yeah, General, I suppose obviously a lot of complicated news the last year or so with huge cuts or just a dissection of USAID or other kind of traditional forms of American development aid or development agencies or indirect support that might support nonprofits but those that rely upon the U.S. government funding for the work they do across the world. On the flip side, one of the only major parts of the U.S. government that probably will see a huge increase in funding, the recent proposals for the administration are talking about well over $1 trillion defense budget, perhaps 1.3, 1.4. If that's the case, even if it's a relatively small part of our defense budget, if those dollars can go up, do you think kind of the U.S. defense kind of development assistance could maybe fill some of those voids that have been created by the kind of disembowelment of other parts of the government?
Well, I do think that there are creative ways with the U.S. defense that could do some healthy defense diplomacy, as one might say, much like if it's the hospital ship or something. Most people don't realize that 80% of the Army's doctors are actually in the Army Reserve. Why is that interesting? Well, okay, so they do 2 weeks a year of full-time work. Why isn't that something that we can harness to bring them to different communities to do what is often called med readies and the like? But why are we not harnessing those capacities? Okay, if you're going to fund that, if you're going to fund the National Guard or the Reserve, why are you not having those forces go in and do more civil affairs, get your engineers to build something, but be it done in tandem? That's one of the things that Admiral Stavridis was brilliant with, is he had us do it in tandem with the Department of State throughout Latin America, and we would go in and it would build capacity for our military while doing something that was healthy in nature. And I joined the military to help people because I saw it as a capable organization that in times of disaster and need that could help and step in until those organizations rallied and got ready and took over for it. And so that for me, whether it's the logistics, it's the engineering, it's the medical piece, I do think that those things could be harnessed and used. Because to me, the best way to use your skills is by actually doing something. It's not by sitting in a reserve center or doing a pretend training at Fort McCoy, Wisconsin. And I think it would also inculcate the thought to service members that the ultimate goal of any military is stable societies and helping other nations. I want other nations to have stable societies where they can function, work, and move forward.
When we help other nations ultimately help us as well. Dusty, I have one last question for you. Um, what would be the one thing you would share with this group that's on this call that would kind of lay the foundation for the rest of the afternoon? What would you share with them?
I would share with this team that I would share with you that we need you to build trust and have a bias for action. Move forward and really let your voice be heard and do it in a way that helps bring people together and unify. To me, Medical Bridges is a unification factor for the world to really harness superpowers. I mean, we don't go anywhere in the world where we are not going to need the capacity that Medical Bridges brings. You're just not. And so, how do you apply your skill set to enable this to happen and be part of something greater than yourself?
Major General Dusty Schultz, what a terrific American you are. What a terrific citizen of the world that you are. Thank you for all the services you've done and all that you've yet to do. We are so grateful you joined us today. Many thanks.
Walter team, thank you all. This has been a really special moment for me as well.
Thank you, General.
Thank you.
And now we're turning it over back to Sonali Corday, our event chair, for a terrific panel to follow. Sonali, it's all yours.
Great. And thank you so much for that discussion. And thank you so much, Dusty. I am reminded of all the times that we worked hand in glove with our military colleagues on various disasters around the world, and always appreciate your colleagues' professionalism and wisdom in giving a hand to civilian initiatives. So thank you for that. So to start with, let me introduce this next panel, which I'm so thrilled about. It's such an honor to be moderating this panel. Our next panel really needs no introductions. They are famous and renowned, but I will try to do my very best. So first up, let me start by introducing Professor Andrew Natsios, who is a longtime American public servant, diplomat, international development leader, professor, best known as serving as administrator of USAID from 2001 to 2006 and U.S. Special Envoy to Sudan. Professor Natsios, I think you are a former Massachusetts state legislator. I think you might have worked on the Big Dig at one point in time, if I remember correctly. And you are now at the Bush School of Government and Public Service. Fun fact, you were my boss. You don't know that, but you were. I entered government and USAID under your watch, and was basically under your tutelage, whether you know it or not. So everything that has gone wrong or right in my career is in some way attributable to you. So thank you for that. Next, let me introduce Dr. Peter Hotez. Dr. Hotez, are you on? There you are. Great. Another renowned, brilliant figure in my life as I was coming up working on malaria and infectious diseases in my career. Dr. Hotez, again, needs no introduction, but is a leading voice in vaccine development, science advocacy, a leading advocate on neglected tropical diseases, and your work has improved the lives of millions, and is a famous science communicator and author, and speaks to the lay public about vaccines and misinformation, disinformation. So thank you for all of your work.
And don't forget, I also work for Professor Natsios as well, of sorts.
Oh, wow.
I think that's a little bit of an exaggeration, Peter. But
in my cherished appointment at the Scowcroft Institute, which I love.
Excellent, excellent. And then last but not least is Dr. John Nkengasong. Dr. John, are you? There you are. Distinguished global health leader, pioneer in public health systems across Africa and beyond. He served as the last U.S. Global AIDS Coordinator and led PEPFAR under the Biden administration. Also the founding director of the Africa Centers for Disease Control and Prevention. Just a world leader on infectious diseases surveillance, epidemiology, HIV/AIDS, an amazing person, and I'm so thrilled to call you my friend and also my inspiration, Dr. John. So welcome, Dr. John.
Thank you.
Great. So I'm going to start off with the first question, which is going to go to all of our panelists. And it's very simple. How do you see the current state of global health today? What do we need to do to address immediately and urgently the key issues? And what are the opportunities and solutions we should seek to capitalize on, whether it's vaccines or new interventions, or how do we use AI? So I'm going to start first with Professor Natsios. Over to you.
Thank you. Well, I think you can't separate global health from the general aid community, and you can't separate the general aid community from the condition of the international system. So there have been layoffs of, I think, between 10,000 and 13,000 people within the UN system. There have been layoffs at the Global Fund. There have been layoffs at the World Health Organization. Needless to say, we've lost USAID. It legally still exists, actually, but most of the staff has been fired. The biggest loss, in my view, were the AID missions, of which there were 60. And half of the staff of AID were not Americans. They were Nigerians or Brazilians or Peruvians, whatever. Wherever we had the mission, we had local staff who were in many respects the continuity between one Foreign Service officer who had to circulate by federal law. Many of these local staff went on to become heads of state. The First Lady of Peru under one of the presidents of when I was administrator, she worked for aid for many years in the aid mission as a Foreign Service national. The first president of Costa Rica worked for AID for 10 years in the mission. The first woman vice president of El Salvador worked for AID as a Foreign Service national. So I think all of these things are related to each other. I don't think I think there's a huge instability in the global health community generally because of the aid cuts, but and it's not just what happened a year ago, it's what's happened since. Just within the last 2 weeks, the global supply chain contract with Comonix has been terminated, and they've been told to end operations by the end of May. That's not exactly a long period of transition. And since a lot of other entities, including ministries of health, rely on the old aid system and the old NGOs and contractors and scientists, it's very disruptive. So I think there's a huge amount of disruption in the community generally. While the administration says they're still purchasing the antiretrovirals for AIDS, the reality is that the supply chains have been disrupted. And a lot of the health clinics, there are about 10,000 health clinics that are around the world that are supplied to the supply chain system. And they're not getting the drugs. If a person, and we have two scientists here, two doctors who can explain this to you, but it doesn't require an MD from Harvard Medical School to understand this. If you're off antiretrovirals for 72 hours, your viral load will begin to increase. And within a short period of time, you'll become infectious again. There are two big benefits from the PEPFAR program and the Global Fund. One was to slow down the spread of the epidemic. But the second one, by taking the antiretrovirals and getting the viral load really, really low, you no longer become infectious. And that's now being compromised. And the second thing is there was a very extensive system within AID to work with ministries of health and the NGOs and private sector to immunize children. That's all been disrupted as well too. So it's the malaria program, the PEPFAR program, the family planning program is completely gone. They just shut that all down. And finally, the child and maternal health programs, which involved all of these vaccines and immunizations. At the same time, Russia, I mean, about 50% of the anti-vaccine messaging studies show come from the Russian intelligence service. This has been going on even before COVID. This has nothing to do with Trump or Biden or anyone else. It was one of their tactics to undermine confidence in scientists and in the healthcare system. They did it against the US and Western Europe, but it's affecting Latin America and Africa, where we did a study on vaccine hesitancy in Latin America through the Scowcroft Institute. Dr. Christy Blackburn did with 4 universities in Africa and African scientists. And it's very interesting how similar the data was that came out of these local surveys as to why people were reluctant to use vaccines. The internet is not something you can contain within one country. So if you have a lot of garbage on the internet about vaccines, it gets out to other people too. And even if it wasn't directed toward them. Anyway, so I think there's huge turmoil, there's disruptions in the system. The system was fragile anyway. Now, some countries are doing better than others. Tanzania was way ahead of others, and so they had put in place contracts, so they're less disruptive. Botswana has much better ministries generally, and so they're not disrupted as much. It depends on the country. A lot of this is locally specific.
Thank you so much for that overview. Next, let's hear from Dr. Hotas.
Well, thanks. My answer may change by tomorrow morning or after 8 p.m. tonight. So holding my breath to see what happens. We're definitely living in a very dark and scary time. Well, first of all, I think there's nothing we can't change by having my 2 mentors on the panel, Drs. Natsios and Nkengasong, back in a high-level position in the U.S. government. So once that happens, everything will start to autocorrect. But until then, we're certainly in difficult times. As everyone knows, I develop low-cost vaccines. Our low-cost COVID vaccine technology reached 100 million people in India and Indonesia, and I still think those kinds of things are possible. I mean, what's clear is, at least in the vaccine space, technology has reached a point where we can make a vaccine fairly quickly against almost any new emerging or neglected disease pathogen. And using the approach both for Ebola in 2019 and COVID-19 was, if you throw enough different technical approaches, including mRNA and vesicular stomatitis virus-based vaccines and adenovirus and particle vaccines and our traditional recombinant protein vaccines, you can be pretty assured you'll make a good vaccine. So our technology the science isn't the problem. I mean, of course, there's always unexpected glitches and things happen, but our technology has outpaced our political, social, and financial instruments that we have to get those technologies out to the people who need them. And that's our biggest challenge. And now it's compounded by, as Dr. Natsio says, by rising anti-vaccine activism. And I get involved with that because I also have a daughter with autism and intellectual disabilities. And 10 years ago, the National Institutes of Health, Tony and Francis Collins, asked me to talk to Bobby Kennedy, and I had a year of discussions with him, mediated by Tim Shriver. And you can tell I was not very successful, but listening to all of his crazy stuff and debunking it, I've put a pile of notes together and wound up writing a book called Vaccines Did Not Cause Rachel's Autism, and which debunks the whole anti-vaccine movement. And I've watched it accelerate since then. And before, it started out with false claims around autism, and then kind of took a political mantle around 12 years ago around this banner of health freedom, medical freedom, kind of libertarian, sort of extremist libertarian concepts that sort of perverted the whole concept of libertarian ideologies even. And then around 3 or 4 years ago, it took a third part to it, which was a very corrupt health and wellness and influencer industry. And if you ever wondered why there are always anti-parasitic drugs, ivermectin, hydroxychloroquine, fenbendazole, it's because it's available in bulk. You could buy it up for cheap and repackage it, and you sell it with a $1,600 telehealth visit. It's a very corrupt industry. But, for that industry to thrive, they've got to go after the science and the scientists, and that means going after vaccines. And unfortunately, that's what's being exported right now, I think, more than anything else, is the health and wellness influencer industry. Dr. Nazi was right about the Russians. What the Russians were doing, this was documented before the pandemic, was Putin was flooding our internet both with anti-vaccine bots and trolls and pro-vaccine bots and trolls, because he had a different goal. He didn't really care about the issue. He just was looking for divisive issues to create discontent among democracies. And unfortunately, vaccines were on that list. But now, the wellness influencer industry has become very powerful financially and unfortunately linked to politics as well. And that's what's being exported. And so, because I'm based in Texas, we do a lot of work in Mexico and Latin America. And that's for the first time now. I'm seeing that US style anti vaccine movement being exported south of the border. Before I used to go down there to either Mexico, the Pediatric Society, or Colombia or Brazil and congratulate the pediatricians on keeping the line and holding off all the anti-vaccine movement in the US. And no longer it's widespread there. And now it's moving into the African continent, although it's not easy to document because you can't just do a PubMed search and put the keywords anti-vax in Uganda, let's say, and get anything. It's on people's WhatsApp and on their cell phones, and but I'm pretty sure it's there as well. And so, despite the fact that we can now make a vaccine against almost any pathogen, there is that disconnect, and we're seeing now sharp declines in measles vaccination rates. And so, measles is returning not only to the U.S. but other countries as well, and pertussis, and of course, I'm very worried about polio. So, how we can restore public confidence in vaccines and recognize that it's not due to, in my view, what the scientists have done or what WHO has done or not done. It's due to a very aggressive, coordinated, politically motivated, and financially motivated anti-vaccine movement that's now dominating the internet, dominating the podcast, dominating Fox News at night, and that's going to be our biggest challenge, I think, right now.
Yeah, thank you so much for that. And I actually never knew that about the anti-parasitics industry. So thank you for that public service announcement. Let's now turn to Dr. John. Dr. John, what are your thoughts?
So thanks, Sonali, for including me as part of this panel. I think it's hard to say anything useful after Peter and Anasios have summarized it all. But as the saying goes, everybody has said everything except that I've not said it. So let me just repeat what some of what they have said. But maybe couch my comments in three dimensions. One is the collapse of global solidarity. Second, the need for political levers and leadership. And thirdly, disinformation, which I think we must take seriously. We've diagnosed a lot. Maybe if we look at the data since 2021, so as the previous speaker stated, the decrease in global funding didn't start yesterday. It didn't start during the Trump administration. It started in 2021, paradoxically, during COVID. I mean, 2021, we were still in the middle of COVID. The development assistance for her was around 80 billion. And it dropped from 2021 to 49 billion in 2024, and now we're at 39 billion. That's the fact. So in other words, between 2021 to 2026, we've seen a 51% reduction in development assistance for health. That is space that is so difficult. We all talk about domestic financing, Governments do not just turn around in developing countries and find the money to replace that huge funding there. Another thing we should remember is that this is all global. In the spirit of the global solidarity collapsing, it's not just the United States. It's just that the effect of the United States effect is always very powerful and domineering, because at some point we contributed about 40% of global health funding, 40% in 2023, 2024. But if you look at other major donors like the UK, recorded about 40% reduction in global health funding. France recorded 33% and Germany 12%. So there's been a total trend, a tendency in the reduction. I mean, but if you translate those percentages to absolute number, that 57% for reduction in the United States corresponds to $9 billion. Whereas the UK's 39% is about $700 million. So we are looking at billions versus millions across this country. So if you combine the reduction in global health funding from France, Germany, and the UK, it's still a small fraction compared to the 9 billion that the United States has. So overall, collapsing global solidarity. That leads me to my second point, which is, where are the George Bushes of the world? We talked about global health systems, but we should be talking also about systems for global health. And systems for global health include political dimensions, the kind of dimensions that we saw with President Bush in 2001, 2002, the Kofi Annans of the world, exercising diplomacy, President Obasanjo creating the Global Fund. I mean, that was leadership at its leadership for global health at its highest. For the first time, the UN Security Council passed a resolution 1308, which considered HIV/AIDS to be a national security threat, which is unprecedented. During the entire time of COVID, there was no UN Security Council resolution, but we had one in the early 2001. That really is important to emphasize that, because that became the rising tides that raised all ships in the sea, that huge HIV influx of funding that created PEPFAR, the Global Fund, and the rest. So I think as we wrap our heads around global health, I mean, there are three ways that global health will go. It will go nowhere, it will go somewhere, it will go anywhere. We should think of political drivers. What are the political drivers who are those that we need to take global health politically, hang it on their neck, so that they carry that burden, and it's only politicians. Now, Peter, you talked about vaccines. I mean, I led the COVID response in Africa for 3 years before joining the Biden administration. We came to a scenario where vaccines and diagnostics were available, but there were no delivery systems for that. So you do no good to the population, right? Because vaccines without vaccination is no vaccine. But it all required, the time the United States started engaging, there was vaccination there. So again, political drivers will be very, very important as we reconfigure Global Health 2.0 or Global Health 2.3. My last point is disinformation. I've been in so many forums that disinformation, misinformation is discussed, diagnosed, but I've hardly seen concrete advocacy rallying around or actions that are very deliberate, because the problem is only increasing. I think we've seen this over and over. And again, if you have a good vaccine, a good therapeutics, and Russia continue to do what they are doing, and others amplifying it, we are not going to deliver that in the community. So what is the role of community? I mean, community advocacy, leadership in disinformation. I don't know the answers to that, but to me, it's one of the greatest threats. So those are 3 points I'd like to start this conversation with.
If I could just build for 1 second on what John said, he points out something very important that I don't think a lot of Americans are aware. Our decade of global health that began in the year 2000 occurred in a Republican administration. It was many leaders from the Republican Party, people like Tommy Thompson and Dr. Natsios and others who led this. And why we were so successful. And I moved to Texas 15 years ago, and I used to call them George H.W. Bush, Jim Baker Republicans, and they were all in, right? And they still are all in. They're all in on science and medicine and global health. And how do we reconnect that, I think, is and say, this is, one of the great legacies of the Republican Party, and it's just been really tough to make those statements without, people accusing you yourself of becoming a political figure. I really don't care about your politics. That's your right as an American, but how do you say don't adopt this stuff because it's so dangerous? And it's one of our great challenges.
There is
Thank
a
you
book
so
by,
much. Yeah,
if I could just add, there's a book
please.
by Robert Kaplan, one of my favorite writers. He's a realist, but he's a humanitarian too. His first book was actually on the Ethiopian famine in the mid-'80s under Mengistu that killed upwards of 1 million people. But we had him come and speak a couple of times at the Scowcroft Institute here at the Bush School of Texas A&M. And he became a friend of mine. He published a wonderful book, wasn't a bestseller, unfortunately, called The Great American, the Good American. It's a history of Robert Gersoni's life, who was the greatest humanitarian researcher, along with Fred Cuny of our era. And Bob was my one-person humanitarian CIA. I would send him into civil wars and to find out what was going on in terms of health and nutrition and food. But Robert Kaplan wrote this book, came out like 2 years ago, called Wasteland, and it compares what's going on now with Weimar Germany in the late 1920s, early 1930s, that led to Hitler's rise later. And he's not making a comparison with Hitler. He's talking about the chaos that existed in Europe intellectually in the late 20s, early 30s. That was a blowback of the First World War. It's a depressing book. I mean, all his books are a little depressing to read. But when I asked him, I said, well, I think it's a result of two giant shocks. The first was the 2008 pandemic, 2008 economic collapse, and then the pandemic with COVID. There are two giant shocks, economic shocks, but also intellectual shocks. And he said it is that, but it's also the internet. We haven't had the internet to deal with the internet before. There's been an anti-vaccine movement since the Revolutionary War, but it was never dominant. General Washington required everyone to be vaccinated against smallpox, or we would not allow them in the Continental Army because it was destroying the rebellion. The Boston Town Meeting, 1802, voted to require everyone to be vaccinated against smallpox. This is at the town meeting level. The Massachusetts legislature, which I was a member of for 12 years, I'm from Massachusetts originally, 1852 said every school child must be vaccinated against smallpox, or they will not be allowed in school. When Texas finally voted to require vaccines? 1972. So if you look at the pattern, there's a suspicion of the government, and I don't believe in giant government, but there are certain things the government needs to do sometimes. And public health is one of them, in my view. It's a national security issue for me. And when you ask a Republican, why would you be so involved in humanitarian issues? And I said it's a national security issue. These are threats to our civilization, not just our civilization, but global civilization. And I don't think the world's going to end because of nuclear war or even global warming. It's going to end because a pandemic at some point in the future is going to get out of hand and we can't stop it. And I'm very worried that's going to happen. The mortality rates for COVID were actually quite low in terms of the percentage of people die. We didn't know for years later until what the death rate would be. But I mean, the global community did get together, and we got through it. But it did cause huge economic problems, and it killed, if you do the extrapolations, 20 or 30 million people, which is a huge number. Not as bad as 1918, though. The upper end of the estimates in 1918 were that 90 million people died, which is 5% of the world's population died within 6 months in 1918. And if you look at the death rates during the bubonic plague epidemics of the medieval period, some estimates were a third of the entire population of the world died in the 12th century because of the bubonic plague. And there were successive outbreaks of it, and it was absolutely catastrophic. In Greece, where my ancestors are from, 60% of the population died. And I think it was, I can't remember which century it was, but it was just devastating. It was during the Byzantine Empire. So this is the notion that we just destroyed the infrastructure of our aid program, for me, is absolutely unbelievable. It's the first line of defense. You don't stop a pandemic at national borders. You stop it wherever it starts. When people say, well, why didn't you stop COVID? It didn't start, it started in China. We know it started in China. There's no aid mission in China. There's, WHO was under the strict control of the central government there. And I know the Chinese government did not start COVID, but they did hide. We now know they did hide the outbreak for months before it became public. And that's the other thing. We have to have transparency early on if you're going to stop something.
I mean, here's, by the way, I'm writing a new book which retells the history of Texas through the lens of our epidemics. How cholera put the Texas Revolution on pause for 3 years and changed the outcome. How the yellow fever kept the ports in Confederate hands, and how malaria nearly decimated the Austin colony. And you'll have to have me up to talk about it, and maybe Ronan too. So that's going to be I'm really enjoying this. But it's nice not talking about Kennedy and anti-vaxxer stuff for a change. And so I needed a break from that. But I think what happened in my view was, there was a big pushback against vaccine mandates, and I understood the pushback. I don't necessarily agree with it, but I understood it. And, if you look, for instance, the CPAC conference of conservatives in Dallas in July 2021, they brought in Representative Matthew Cawthorn from North Carolina, and he says, well, first they're going to vaccinate you, and then they're going to take away your guns and your Bibles and this kind of nonsense. And I actually didn't see that as so damaging. But the damaging part was they didn't stop at railing against mandates, because then they brought on all the wellness influencer industries at that CPAC conference, as they did at Fox News, to denigrate the effectiveness and safety of the vaccines. And that's where they crossed the line. And so Tucker Carlson, Laura Ingraham, Sean Hannity, this is documented by two groups, Media Matters for America and a research group out of the Federal University of Science and Technology in Switzerland, documented every night they brought on those guys to falsely discredit the effectiveness and safety of vaccines. Starting out with a pushback against mandates, fair enough, you can have that discussion. But then to falsely put out all that disinformation about the vaccines, and then Joe Rogan piled on, right, and started pushing the ivermectin. And so if you're watching, Tucker Carlson and Laura Ingraham, Sean Hannity every night, watching Rogan podcasts, you made the executive decision, say, I'm not going to get vaccinated, and you paid for it with your life. 200,000 Americans needlessly died because they refused COVID vaccines during that Delta and BA1 Omicron wave. And that's what's spilling back over onto childhood vaccines in the U.S. and now globally, and why, measles erupted in Texas in exactly the same place, those rural conservative areas of West Texas, the Panhandle, where people died because they refused COVID vaccines. And that's what you're seeing now across the country. And unfortunately, that's what's being exported because, you're right, Dr. Natsios, the game changers, well, three things, actually. It's a full-on adoption by an extremist element of a political party. We hadn't seen that before. The money being made by the wellness and influencer industries, and then using the internet as the vehicle for it. It's become very powerful, and we're exporting this stuff now. And the U.S. is good at exporting music and film, and now we're exporting this stuff, and it's really tough to put the genie back in the bottle now.
It is tough. I was hit by a wave of nostalgia when Dr. John mentioned Kofi Annan and George W. Bush, because that was in some ways like this golden era of U.S. global health initiatives. And I happened to be lucky enough to be at USAID at the time in the Global Health Bureau to to see it all unfold. And so all three of you are experts, and not only experts, real drivers and real leaders in three major global health initiatives that were US driven. And I want to ask each of you about your different experiences and basically how you were able to push it forward and advocate for it and make it happen. And Dr. Hotez, I'm going to take you away a little bit from COVID and vaccines, but to NTDs and neglected tropical diseases, because this is a program that has not gotten the credit or the visibility it should have, but I think it has improved the lives of millions of people, particularly in Africa, and was an example of an incredible public-private partnership with donations of anti-parasitic drugs. And I'd love to just hear your reflections on that time and your role in basically getting it up and running at USAID, because it is not easy to get those congressional earmarks or to get that funding and to get all of that infrastructure stood up. So we'd love to just kind of hear about your experience on that specifically.
Sure. Well, I think, it's a little bit of, luck, a little bit of timing, and a little bit of having people with great wisdom and leadership in global health, like my two colleagues, who helped a lot in that period. So, if you remember, the original version of the SDGs were the Millennium Development Goals, and they were launched in 2000. And I thought they were pretty good. But the one for infectious diseases was to combat HIV, AIDS, malaria, and other diseases. And that was a game changer because I think it helped, launch PEPFAR and the Global Fund to fight AIDS. They added TB and malaria and the President's Malaria Initiative. And that was terrific. The only flaw in it was they had a third category called other diseases, and that didn't get anyone very excited. And so, as someone who had devoted my life to the biochemistry and new interventions like vaccines for other diseases, I said, no, this isn't going to work. And so I partnered with two colleagues in the UK, David Molyneux, who headed the Liverpool School of Tropical Medicine, and Alan Fennick at Imperial College. And we did kind of a rebranding exercise and kind of made up a term called neglected tropical diseases, and it sort of stuck, and recognized that there's a lot you could do by packaging existing medicines that are being donated by the pharma companies. And I remember, visiting you, Dr. Natsios. I remember visiting, Tommy Thompson, and we made the case that you could put these together for 40, 50 cents a person per year, and people got it. I think partly it's because they were buoyed by how successful PEPFAR was and the President's Malaria Initiatives, and they were open to yet another intervention. And we kind of slid that one in there. And within a year, there was a $15 million appropriation to USAID. And, that may not sound like a lot of money, but that was enough to treat 30 million people. And then we were able to persuade the Obama administration to continue it. Actually, it was Zeke Emanuel, who was then working in the Obama administration, who helped champion it there when I went to see him. And it always kind of flew below the radar screen because it didn't reach the billions, but it was $100 million. But it was enough to get a lot done. And, over 1 billion people were getting treated a year. So it showed that, through advocacy, in good timing, you could do a lot. I'm worried about its future, and unfortunately, what happened was even before the debacle at USAID, the UK government pulled out of their support for it. They were matching it almost 1-to-1. What was then called DFID, the British Department for International Development, and then with Brexit, they pulled out, and so that stung a lot. But now it's going to be very tough to maintain. When I had the chance to meet with President Bush at the Baker Institute, they honored him, and told him what reminded, of course, he was the global health president. But then I said, and one of your most impactful programs, I don't think you also get enough credit for, is the NTD program. And he's quite aware of it. And, again, how we can get that back online, I think is going to be a challenge.
Thank you. Dr. John, can you share your reflections on leading PEPFAR and key lessons learned? I mean, you definitely changed course this last 4 years. Would love to kind of hear about what you think is the state of the epidemic and some of your reflections from your time serving as PEPFAR coordinator.
No, absolutely. I think and I hate to say what I'm going to say, but I will say it anyway. When I stepped into that office in 2022, and after 6 weeks of looking at where the program was, it occurred to me that the biggest elephant in the room was sustainability. That the US has been doing this for more than 21 years, and there was nothing that suggested to me this kind of thing that is not science, it's not data, but it's sort of that feeling that no, this cannot continue the way it is. I mean, its current form. So I champion, as you know, this sustainability. I was terribly unpopular the first year or even second year because people said, well, just keep doing what others have been doing, coordinators, you test people, put them on. I said, I'm not saying you should not do that. I'm saying you have to do that, but we have to be thinking of a sustainability. I said the US government and the United States people, Americans cannot guarantee the treatment of millions of people in Africa for the rest of life. I said that is just common sense. We have to talk about sustainability because that is. And once that argument, of course, I persisted and insisted that it has to be, dominant. And before we left the Biden administration, as you know, we had developed sustainability roadmaps. And I engaged 33 head of states in Africa. I went to the African Union and met with 33 head of states all in one room. And I said, look, the US and the United States came to you in 2002 and supported and met you at a point of need. HIV was an existential threat. But you cannot not think of taking over that responsibility. We are no longer in 2000 where HIV was devastating. You walk down the streets of Kampala or Nairobi, you saw people with sunken jaws, and I said, that period is over. So they said, what do you want? I said, you issued a declaration committing yourself that you have an extraordinary summit of head of states to review 20 years of fighting this deadly disease. Second, develop a roadmap to 2030 on how you finance this, with a contribution of partners, but you can't just leave this to partners. So anyway, was it prophetic? It was. Here we are today where, we are not even talking about how many people have received their treatment, how many people have suppressed viral load and whatever. It's very transactional. We are signing these health compacts. I really don't know what that is. I'm in Tanzania as we speak. And everybody is confused of what is the role of the United States there. So my greatest fear is the gains that we made over close to 25 years in fighting HIV/AIDS may be reversed. As it was earlier mentioned here, HIV is a very clever virus, and it doesn't take a lot for it to come back. And HIV has become a generational thing where the young people that we see on the streets in Africa don't even know what HIV is. They didn't see HIV. And because they didn't see HIV devastating the continent, it's very difficult to draw their attention. And so I think that is key. So my point is, two lessons I drew from sustainability was the way to go, but it was, of course, like any concept. It was, I was fought. I wasn't fought by the Africans who were receiving the PEPFAR money and support, but I was fought by our own colleagues through the agencies where they saw that as their empires. What will happen to my empire if, what John is talking is about sustainability and what will happen to me? It wasn't what it was. So next time we're designing big programs, we should build sustainability up front and discuss a way, design the program to get in and design a way to get out. How do we get out of that? Because it became a very, very touchy issue about, and it almost became personal about, he doesn't know what he's doing and whatever. But here we are today, we are getting. Second thing is that, and last lesson that, we all learned from PEPFAR is that, boy, I can't count 5 global health successes without the HIV. I mean, the fight against HIV is not over. I mean, as I just indicated, but we are not in 2000. Okay, we are not in the year 2000 where HIV was, I mean, eliminating, almost threatening to eliminate countries. My last meeting with the head of states was with President Basisi in Botswana, and I said to him, look, we are here to discuss sustainability, and he turned to me and said, Ambassador, I fully understand what friends do for friends, and friends don't remain forever. Helping friends, they help you, they meet you at point of need. We recognize we have to take our responsibility. Unfortunately for him, after 1 week, he was voted out of office, or fortunately for the country, democracy worked in there. But the point I'm making here is that it takes a long-term planning and sustained engagement to change a trajectory, whether you are dealing with polio or the only virus that or disease that we've eliminated, that is smallpox. It takes time to do that. Our mindset with this fighting pandemic cannot be transactional, and it cannot be pandemic memory loss, where after COVID, during COVID, we say, oh my God, never again. This will never happen. And again, but shortly after that, we started going to restaurants, doing traveling without the COVID test. We forgot about it, and now we are dismantling those same systems that were put in place to prevent disease outbreaks and pandemics there. So my greatest worry is by dismantling those systems, we become even more vulnerable for the next pandemic, because there's no system now for early detection and reporting in many countries there. And these are the same system that we set up. Look at CDC, just to end. I always look at the United States and say we should be proud for several reasons in global health, the leadership in global health, HIV, polio, etc. We should also be proud of setting up institutions like USAID and CDC, to the extent that the world started cloning those structures, right? The European CDC, the China CDC, the Africa CDC. Then we turned around and said, oh, we really, really mean that. We didn't really mean, we deceive you. So this CDC thing is not, we are not very serious about it. Now the whole world is confused about what do we do with all these CDCs that you all said we should set up, and we set that up. So again, our leadership role in global health is so important. The world is looking at us. They are very confused. I mean, when I left government, I've been traveling around Europe, Africa, and Southeast Asia, and their thinking is the same. I mean, what do we do with all these concepts and constructs that we borrowed from the United States, and now we are stuck with them in our hands?
Let me just add one thing, Sonali, here. I am coming out with a book in November on USAID and foreign aids called Guns Are Not Enough, Foreign Aid in the National Interest. And I've been writing it since I left aid, but then I had to put in 2 very painful chapters over what's happened in the last year. And I've reflected on what's happened. The central argument of the book is that aid is not about capital formation. That's not what development is. It's about institution building. And that's how you make programs sustainable, is through institutions. And you do capacity building to build the institutions. There was an effort by Peter McPherson, who was the celebrated head of AID under Ronald Reagan. If you ask the career people, historically, they would rank him one of the great aid administrators since the founding of the agency. Peter was the president of the Association of Land-Grant Colleges and Universities, which educate the bulk of college students in the United States. Lincoln created, through the Morrill Act, the land-grant college system, of which Texas A&M is one element. And so he tried to get an amendment through the PEPFAR legislation to allow the money to be spent for capacity building and institution building. And the advocacy groups in the United States stopped the amendment. I just couldn't believe it. They said, no, only buy antiretrovirals. I said, yeah, but the thing's not sustainable. Dr. John is absolutely correct. This was not last year. This was 10 years ago. We could not get them to change. And they were so militant, they accused us of killing people in the developing world because we were diverting money from drugs. I said, there's no drugs without institutions to deliver the drugs. Don't you get the connection? They're not development people. The advocacy groups are not development professionals. Or they would understand you cannot disconnect any development project from institution building. And so it's the most invisible thing that AID would do, and yet it's the most important.
So
And
so along so along
Very
those lines, you know what, maybe you want to add this to your book. You know what one of the real result of the Rockefeller Foundation and the Rockefeller Sanitary Commissions was in the early 1900s? It wasn't mass treatment of hookworm. That really did nothing to affect the rates of hookworm. It was the fact that they used that to build a whole infrastructure of public health schools and public health,
yes,
state and county local public health systems linking with the public health schools. That was what the sustainable part is, and it's
absolutely
still an
correct.
effective part
amazing.
of the legacy. So I think you're absolutely right. I think this is.
Speaking of legacies, I want to ask Professor Natsios about one of your big legacies, and I had the fortune of being one of your worker bees on it, which is the President's Malaria Initiative. And speaking of career descent, there was a bit of career descent because the PMI represented a completely new way for USAID to lead a health initiative. So, would love to hear your reflections on the President's Malaria Initiative and your time then, because I recall it being a very bold move on your part and also a feature of bureaucratic prowess that you basically managed to keep it at USAID versus it migrating over to the State Department. So any reflections there? And then after
Well,
that,
I
we
do.
want to turn it over to Ronan for some questions from the audience. So just a preview.
Okay, so let me explain why Sonali just said this. The aid system, as it was designed, was highly decentralized. I am a radical localist in domestic policy and in foreign policy, and particularly in aid. I think each country's different. Their cultures are different. Some countries like Ghana had an imperial history with the Ashanti Empire, so they're used to hierarchies. Other countries don't have that history. The Ethiopians have a history of bureaucracy because of the Ethiopian emperors, somewhat repressive, I might add, if you're a minority group. But so the importance of local uh, uh, ownership was based on the notion that these initiatives should come up from the bottom. Now, that did not impress anyone in Washington. It's not just the White House. It was OMB, and it was the State Department, and it was the Congress. They said, no, Andrew, you can talk about that all you want to. We want a highly centralized program that's standardized, just like the PEPFAR program, which the PEPFAR program actually says the exact percentage we have to spend on buying antiretrovirals, how much we spend on prevention, how much we spend on condoms, it's all and on treatment. It's in the statute. And we had to monitor that with compliance officers. Now, I preferred a much more local approach because each country in Africa is different. Tanzania is very different than what's going on in Sudan. There is no government in Sudan right now. So you have to use a different approach in Sudan than you do in Ethiopia or in Tanzania. So what I did is to sign a memo centralizing control over the whole PEPFAR program. Now, the career service did not like it. The foreign service, the civil service at the end of this is I said, you have a choice. We can go along with this, with a memo, or we can transfer the whole thing to state. No offense, Dr. John, but we don't really need the State Department telling us how to do this stuff because 25% of the staff are health professionals, MPHs, epidemiologists, nurses, pharmacists. We have the expertise. That's not the issue. The issue is how we're going to manage this and tell the Congress exactly how every dollar is spent. So I signed the memo. I sent it to the White House. They said, if you do it this way, Andrew, then you can run this, and there won't be any coordination office in state, and CDC will be under your authority. I said, the career people have swallowed the bitter pill, and they agreed to it. And 10 years later, I went back when I was teaching at Georgetown, and I said, what did you do with my memo? And I asked some of the career people in global health. They said, we haven't touched it, Andrew, because we know if we touch it, the White House and the Congress will go ballistic and we'll lose control of the program. So you have to give up something to get something. That's what we did in this program. So I don't regret it. I would do it again. I think we should have done it on PEPFAR, but I didn't do it. I didn't understand why it was so important to the White House and Congress. There is a suspicion that all the money that's spent locally that we don't have control over is misspent, or someone walks away with the money, or they steal the money. And so they don't trust us. That's why they want a highly centralized approach. And that's not just in health, it's in every other program as well.
Well, I think it was a brilliant move. And as I was a health officer going through, we used to hold up that memo, and we had a legal opinion to say that the authority of the prior administrator still stood unless it was specifically overturned. So that memo is gospel to us. We seem to be almost out of time. But I am going to turn it to Ronan to see if there's any questions from the audience, and let him take it away for the last 5 minutes.
Sure. Thank you, Sonali, and thank all of you. I think it's kind of all three of you. We could do 1 single hour or 3 hours with each of you, and would there be so much to talk about? So a good question from the audience, and maybe just to take it to a broader level, because all of you have worked either at a federal level in terms of U.S. funding, or Dr. Nengasoni, obviously with regards to the WHO on a global level, international level. Anne asks, are any of you familiar with Joanne Carter, the Executive Director of Results, an organization that advocates in Congress for funding for international development work? And I suppose in a broader sense, if the U.S. is stepping back from this, who's stepping into that, those empty shoes? And is China the obvious answer, or maybe in terms of other possible allies, in terms of wealthy Gulf states or the Saudis? Is there money coming from other areas, and what are those organizations or nations gaining by supporting some of the work that we are kind of maybe stepping back from?
We had a conversation with the Chinese aid officers, very senior people. When I say we, it was the Asia Society in New York City. This was last year, before the destruction of aid. It was in 2024 and early 2025. We had 4 meetings: Nairobi, Thailand, Beijing, and Washington. There were 2 former aid administrators. There was a senior career officer, Gloria Steele, and the former chief economist for aid, Steve Radlett, who teaches at Georgetown now, and myself, and Gail Smith, who was the head of AID for a while under President Obama. And one thing that people think the Chinese have, this Belt and Road Initiative doesn't exist anymore the way it was before. It has collapsed. Why? Because the countries can't repay the loans. When we were in Kenya, I couldn't believe the anger over people who are paying huge amounts in taxes to pay off all the Chinese loans for all the infrastructure that was built. And they have to pay the loans back now, and some countries just can't pay it. They're defaulting. So Xi Jinping gave a famous speech that apparently was it was a public speech, and it's in The Economist, but people are ignoring it. The Chinese are not going to take our place. They will do it episodically, and I'll give you an example. There is a thing called an institute called the CGIAR, the Consultative Group in International Agricultural Research. The 2 greatest success stories of AID: agriculture and health. Okay, and the Green Revolution was half our budget in the 70s was to implement the Green Revolution of Dr. Norman Borlaug, who was a professor here. He won the Nobel Peace Prize in 1970. He's a friend of mine. We gave him the Marshall Award at AID. This CGIAR are thousands of plant breeders all over the world. It's an international organization. Massive cuts are going on now. It's catastrophic. One of the centers is in Mexico, CIMMYT. It's for corn and wheat. 60% of the bread in the United States is AID bread. I'm slightly exaggerating when I say that. There was a wheat rust spreading around the world. The CIMMYT Center, which is part of this system, in Mexico, which is an international organization, developed a wheat seed that was resistant to this rust that was killing the wheat crop in the South and in the United States and in Europe. It was all over the world. It was disastrous. And 60% of our wheat is from this center. It's not from a commercial company. Well, AID, the State Department, shut down all of these grant programs to the CG system. It was a catastrophe. And guess what the Chinese said? We'll take the whole center. We'll fund the whole thing 100%, but you have to move the center to China. And the Mexican government, even though the Mexicans don't run it, they said, no, you're not taking this out of. And the State Department reversed itself and they're funding it now. What about the other 14 centers all over the world? One is for rice in the Philippines, one for bananas in Nigeria, one for potatoes in Peru. They're all over the world. That whole international system is now at risk of collapse because of these cuts. It is doing enormous damage to the United States. The Chinese are making episodic efforts to take over these institutions. I'm sorry, but if the Chinese took over these institutions, you think they're going to be doing the research just for them, for the whole world? They're going to do it for themselves. They've already proven that. So I think it's a dangerous trend, but the Chinese can't take our place, even though they may try to, they're not going to be able to.
I think we may be running out of time. I think we may have to close here. I know that there are probably some more questions for our speakers, but I'm sure that if you were to email them, they would be happy to engage. I know that everyone has to run. Thank you very much for being with us. All three of you are my personal heroes. Thank you for everything you have done in the world to make this place better and safer and healthier for everybody. We all still have a lot of work to do, and I just want to thank you again for sharing your reflections and your wisdom.
Thank you, Sonali. It was a
Thank
great
you.
panel. I learned so much from all of you. Thank you.
Thank
Bye-bye.
you.
Thank you all.
Okay, so I think we're going to go ahead and move straight into the next panel. And the next one is really taking this down more to the front lines. And so we're going to talk about nonprofits and NGOs that are successfully bridging the healthcare gap and those folks who are on the front lines and doing things in a much more hands-on way, kind of funneling down from the policy down to the front lines. And our next set of speakers have a world of experience working on the front lines and advancing global health through the work of NGOs and local networks. Their work goes on regardless of shifting priorities in Washington and capital cities. This next set of folks have been doing their work, and they've been doing it for decades and are still doing it, and they're doing it with grit and determination and ingenuity. And I'm going to go ahead and start to introduce them. So first, I am very pleased to introduce Dr. Brian Parsley, who is an orthopedic surgeon and has done medical missions around the world. I think that there you are, Catherine, Judge Catherine, who has also accompanied Dr. Parsley on various missions. And welcome to you both. Thank you so much for being with us. Really thrilled to hear about your experience. Next, we have my friend, Dr. Tadia. Tadia, I've had the opportunity to work closely with Tadia recently on some work that we're doing for Gaza. Dr. Tadia is a passionate, results-driven global health leader with a background in medicine, epidemiology, and healthcare systems. She is also the director of global health at Medical Bridges. So welcome, Dr. Tadia. And then we have Javed Siddiqui of HHRD, who is the CEO for Helping Hand Relief and Development. It's been a strong humanitarian relief work around the world, in the Middle East and elsewhere, and has also been a strong partner for Medical Bridges. Welcome to you all. Thank you for being with us. And let's go ahead and start with the first question. This goes out to all of our panelists, which is to tell us about the work that you've done around the world and talk to us about how you and your teams are meeting the moment today. I think we heard from our prior panel, there's plenty to be worried about at this moment in time, and yet you persevere. So would love to hear your thoughts. And first, we're going to start with Dr. Tadia. Over to you.
Thank you, Sonali. That's a great question. So at Medical Bridges, our work is centered around strengthening health systems by providing quality medical supplies and equipment to under-resourced communities around the world. And we partner with hospitals, clinics, nonprofits across Africa, the Americas, parts of Europe, and Asia, supporting everything from maternal and child health to infectious disease prevention and emergency care. So Medical Bridges was founded in 1997, and since then we have served 107 countries. In just the past 3 years, we have shipped 177 containers filled with medical resources to help save lives, and that's the equivalent of 700 tons. So that's 700 tons that would have otherwise ended in the landfill, not because it's not usable, but because of rapidly evolving technology. So what makes our model impactful is that we don't just ship supplies, we focus on a fit-for-purpose model. So that means needs assessment, biomedical review of the equipment, and ensuring that what we are sending can be used immediately and sustainably. And I'll share a quick example of what that looks like in practice. So in Haiti, where communities are often impacted by natural disasters across access to care can be extremely limited at times. So there was a woman in labor who had walked miles to reach a temporary clinic, which was a setup in a church. So when she arrived, it was clear that she needed a C-section, which would have not been possible except that the day before, we had delivered a shipment that included a C-section kit. So because those supplies were there and ready to be used, the medical team was able to perform the procedure and save both the baby and the mother. So today, our teams are meeting the moment in different ways. So first, we are prioritizing efficiency and speed without compromising quality. So that means streamlining procurement, leveraging remote needs assessments, and reducing turnaround so that partners can respond faster to urgent health demands. We are also deepening partnerships on the ground. So rather than one-off collaboration or engagement, we are working toward long-term collaborations that build continuity and trust. And finally, we are being more adaptive. So we live in a world that's very, it's evolving, it's constantly changing. So rather than whether it's navigating supply chain disruptions, funding constraint, or shifting disease burden, our team are finding creative ways to deliver impact without limiting resources. And sometimes that looks like very practical problem solving, like identifying alternative supply routes, like you mentioned, working with you for the shipment to Gaza. It's helping clinics to adapt when patient needs suddenly shift from acute care to managing chronic conditions, which we've seen a lot lately, especially in the African continent. So at its core, our work is about bridging gaps, connecting surplus resources to areas of need, but increasingly it's also about resilience, building resilience within the systems we support. So that could mean ensuring that supplies we provide aren't just useful in the moment, but they strengthen the facility's ability to respond to future challenges, to adapt to changing needs, and to continue delivering care after the initial support is received.
Thank you so much. Amazing work that you've been doing, and very much value your expertise in not just providing the equipment, but also making sure that the needs are met and they're basically tailored to the situation, which is very important. Next, we'd love to hear from Javed about Helping Hand for Relief and Development's work.
Well, thank you very much for the opportunity. I'm really honored to be here today, and I've been listening very intently with all the conversations. Learned a lot. I'm really honored to be partnered with Medical Bridges. The name itself, in my opinion, really shows the value, the bridges that we are able to build between communities here in the United States and North America and around the world. Helping Hand for Relief and Development has been in this field of humanitarian assistance around the world, especially in case of disasters like earthquakes and floods and famines and stuff like that that's been happening around the world. And our partnership actually goes beyond a decade, almost 13 years, almost 12, 13 years now. And over the past decade, we are very honored to provide some key equipment, supplies, medical equipment to locations around the world which really lacked basic health resources. We are currently working in about more than 50 countries around the world. And with the help that Medical Bridges has provided, we have shipped almost more than 270 40-foot containers that were loaded with medical supplies to around about 18 countries. And millions of people have really been benefiting from these supplies. And hospitals that couldn't perform basic surgeries, in a lot of situations where C-sections are required or newborn care is required. It's been challenging for many places, and I've heard so many amazing stories of what this equipment has been able to do. The basic necessities required for a C-section. Sometimes there was a story that was told to me that has stuck in my head forever. They said there was a hospital system in Pakistan, in rural area of Pakistan, which until they have received this care, this equipment, they would cut the placenta after the childbirth with an axe. Just imagine, and the number of children or mothers who passed away as a result of that, because it was just the sheer not having the information and not having the equipment, not having the hygiene kits that are able to perform, or the equipment that are required for this situation. So, being able to restore surgical capacity in rural hospitals, newborn and maternal care and transformation of that's happened as a result of that. Many of the refugee health systems really struggle. I've made, a few months ago, I visited East Africa in Tanzania and Kenya. And I saw those clinics that we were able to arrange under Helping Hand and through the equipment that we actually been receiving with Medical Bridges. Very far-flung areas where it took us hours to get there. And many a times we are told that what would happen if somebody gets sick in those areas, there's really no way for that patient to really reach a hospital in time to be able to be saved. Being able to provide care to these vulnerable populations, it's been very impressive, and I'm very grateful for the partnership and what Medical Bridges has done. I've had lots of conversations over the years with Walter. Him and I share a lot of history and things that we have done in common. But I'm really very happy to share with you that what Medical Bridges has done for so many communities around the world. The equipment that we have been able to really ship to these hospitals, these rural facilities, it's been life changing. It's been life transforming. So I'm very honored to be part of this partnership and thank Medical Bridges for what they have done.
Thank you. Dr. Parsley, we'd love to hear about you and your work overseas, and obviously also hear from Catherine and your perspective on what's happening overseas and your work on the front lines.
Well, I've been involved in medical mission work for over 32 years, and the majority of my time and effort have been spent in providing services in Guatemala with Faith in Practice. And I think we're blessed to have Ben Descopy, who's our CEO, is on the next panel. So we'll probably, I don't want to be repetitive because I know Ben will provide us some good insight and some direction as well. But Faith in Practice is a great example of an organization that had a very, very mild beginning back 33 years ago, 32 years ago, when a small group of 12 ended up down in Guatemala trying to provide service to a very local population of orphans that were located at a healthcare orphanage and facility. And as a result of that initial mission, which started around the same time that Medical Bridges did, because I remember early in my career, Medical Bridges and Faith in Practice were sharing a lot of things back and forth, whether it's excess supplies or the need for supplies in different organizations. So we've grown up together to provide some outstanding services over the years. But Faith in Practice has now grown and morphed into one of the largest healthcare providers in Guatemala. We are no longer a short-term medical mission organization. We actually have a full-time, full year-round service provided to the people of Guatemala. We have over 48 medical mission teams that go down and provide a week's worth of service. We cover almost the entire gamut of healthcare today, the majority of which is orthopedics. And as an orthopedic surgeon, obviously I've been very involved in that growth as well. But we continue to expand, and I think there's been some great lectures here this afternoon, kind of looking at what some of the challenges that organizations have politically, domestically, in providing that services. And I think that might be a good discussion to have as we get into a little more of the question and answer session here a little bit later on how we overcome some of that and continue to sustain. Because as you look at different organizations, you can click on the internet right now and you'll get 42,000 medical mission organizations in the United States. If you take that number and you look at it again in 5 years, only about 5% of them probably are still in existence because they don't have the sustainability, they don't have the direction, they don't have the leadership, they don't have the structure, whatever the reason may be. So trying to find a sustainable program is really a very big challenge. It's a challenge with each organizations, and you're going to have some bumps on the road. But once you overcome a certain threshold, as Faith in Practice has in Guatemala, you're now integrated into the community. And by integrating into the community, when we first started, we were an outsider coming in. The people of Guatemala that needed our services were incredibly thankful and gracious, but we were trying to integrate into a local community, and it was very hard to do. But as the years went on and you continue to be consistent in your messaging, you continue to provide high quality service, you continue to make sure that you stayed above the laws and never got yourself into trouble. And then you started to build networking. You started to build sustainability. And this is where we finally have now integrated throughout the country and have programs that are integrated with the government of Guatemala as well. That's when a program has really found an impact on a country. And Faith in Practice, I tell everybody, from the quality of the work and the value of the work that we do, are probably the third or fourth largest healthcare provider in Guatemala as a volunteer organization. So it's fairly remarkable. And after 65, 70 trips down to Guatemala myself, I married my beautiful wife, who I drugged down there, and now she's become the administrator. She's been the acting CEO for the organization, as well as several other not-for-profit organizations, and brought that expertise and quality to expand some of the things that we've been able to do through this medical mission organization. I don't want to get into Haiti because I went 4 times to Haiti right after the earthquake, and I know there were some interesting discussions earlier today, but that's a problem in and of itself that's almost unattainable.
Thanks. And Catherine, I'd love to hear from you and your perspective on all of it.
Sure, I'll jump in and just say that I really echo all of Brian's comments. Faith and Practice is the organization that we serve through, and it really is just a remarkable impact in Guatemala. More than 17,000 people served annually through 48 teams of volunteers that go down. And I think that I am here to speak also to make the point that you don't have to be medical to serve on these teams and have an impact. Maybe for everyone who's on this call at this conference, to know that you can expand your resources often through those medical providers that you need on your medical mission teams, but also through volunteers who can go and serve in different capacities, which is what I do. I'm not medical, so I serve on the administrative side. And that can really increase the impact of the team. It really is also worth recognizing, and this may come up later in our talk, but that the impact of Faith and Practice and the impact of all of these organizations that we're talking about, the impact is felt by those persons that we serve all around the world, and it's transformative for their lives, but it's also transformative for the volunteers. I know that it's transformative for every person on this call who is a staff member, who is working for an organization and finding personal reward in the work that they do. But it really is as transformative for those of us who serve as it is for those that we are serving.
Thank you so much for that. So a couple threads to pull here. One is just this theme of sustainability, both at the very high policy level, but also at the organizational and local level. And Catherine, I appreciate what you said, that you don't have to be a doctor. I'm not a doctor. I've always felt like part of my job has been to keep all those doctors in line. Just kidding.
That's a good way to put it.
Yeah. But yes, indeed. And Tadia and Javed, really insightful perspectives. And I think your comments segue very well into my next question, which is to say that in light of the cuts in funding and some backsliding in global health, and a lot of these high-level decisions that are made, again, in Washington and Congress and administration, and you can see from our last panel how much the political moment will drive either great ideas and great initiatives or pull it back. And what I want to ask you all is, what is your advice to your colleagues and peers on how to move forward in this environment? And what are concrete actions that the community, and the community I mean us as a community of global health practitioners, should be considering? And really here is I kind of want to get a little bit away from the advocacy question and more towards what is in our span of control. And it goes back to this theme that you have all talked about, which is what can we do in the here and now at the local level, the front lines, to basically keep moving forward. So I'm going to first start with Javed on this one.
Well, it's a great question. And, this is a question that I think all of us have been struggling with, and always asking the question, okay, how can I make a difference that's really long lasting? One of the things, obviously, we are in this humanitarian space, and we are dealing with a lot of disaster scenarios. One thing we have started at Helping Hand to engage in is, I cannot stop a disaster. I cannot stop an earthquake from happening. I cannot stop a flood from happening. I can't do these things. What can we do as an organization to really prepare the communities that we are serving, provide education, provide tools, provide guidance and mentorship so that they are able to respond. They're able to respond because if you can mitigate, you can reduce the effects of these disasters with proper preparation. For example, a disaster happens and now people are trying to recover from that and they don't know how to treat somebody or how to transport someone from point A to point B. That alone could be the difference between the life and death of that person or that community member. So disaster preparedness has been something that we have been focused on a lot recently, educating the communities. For example, we have seen this over and over again. Flood happens, and the community is going to, and I'm kind of veering away from the medical questions here, but in general, the whole humanitarian sector, people will rebuild in the same place at the same height, not realizing that water levels are going to rise again and you are building in the path of. So simple changes can can make the difference between life and death. And how can you reduce the loss of life? How can you reduce loss of property and basically essentials? So that is an area where we think, and then some of these communities are very resourceful in terms of all they need is education. All they need is guidance and essentially maybe some tools. So we have spent quite a bit of activity in this space of disaster preparedness, and it's been really very helpful. A lot of communities have come back and said, we are really benefiting. We have benefited from what you have helped us understand. And we are doing these educational workshops in so many different communities. And has been received very well. And it's definitely helping a lot of communities get back on their feet. Because in many scenarios that many communities we have seen is, unfortunately, governments are not present. And things that are supposed to be done by governments, no one is taking care of them. No one. So people have to help themselves. And I think the humanitarian sector can be a big help in this space. That's just one of the things. The other factor, obviously, as medical bridges have found this very niche and very powerful space, most of this equipment that we think maybe hospitals in the United States are really not taking advantage of. It's been a brilliant work by Medical Bridges and his team that they have really recertified these equipment and are providing this as a great service. And the stories are countless in terms of what changes and how they are allowing communities and countries around the world to really recover on their own. And they're able to use them. They're perfectly fine equipment. So thank you to the team. I definitely to the donors, to the team, and to the leadership for really providing the service. So, but we definitely are seeing the benefits of that. And the last point I'll make is, since the dismantling of USAID, we are starting to see a huge pressure on some of these humanitarian organizations, such as Helping Hand. We don't get anything from the government, and we are a public charity. That's been a big advantage, but at the same time, we're seeing the pressure on the local communities who were on the receiving end from USAID programs. And unfortunately, these communities are reading pretty bad, and then we can see it every day. So whatever we can do to restore some of those services from an advocacy point of view, from really talking to the right people, I think that would be a great service because these communities have really nowhere to go. Thank you.
Thank you. Next, let's turn to Dr. Parsley.
So an interesting question that we can go a multitude of different directions, but I think that each country has its own challenges. So, I mean, it almost has to be individualized. When you look at the government, it was mentioned before in one of the previous talks, and you look at the structure of the country, you look at how you were trying to deliver healthcare. And then you look at the situation that's going on in the United States. I think when you're looking at NGOs or organizations like the ones that are represented here, we're going to sustain ourselves regardless of what goes on with our government, but they just make it either more difficult or easier for us to achieve the goal or to have collaboration that allows us to achieve that goal. I think one of the, Medical Bridges has a unique, uh, uh, addresses a unique need as far as equipment and supplies. Our other organizations like ours sits there and does equipment, supplies, and healthcare providers. Helping Hands does a combination of both as well. And Tati, I'm not sure exactly how your organization is structured, but it sounds like it's people on the ground in providing the services and care locally. If we could collaborate more across NGOs, I think that there is a great value in that because many of us have duplication of services in different countries or in the same country. For example, I went to Haiti for 4 times right after the earthquake, and I was absolutely shocked by the number of NGOs that were there and the complete lack of coordination of any of the NGOs with each other, and they had complete distrust of the government. So it's all isolated events going on in the country. And it was just an absolute disaster and a very, very sad waste of resources. Whereas if global outreach or a broader outreach, as Faith and Practice does in Guatemala now, you're starting to touch bases with more NGOs to bring them together, show what our resources are, what their resources are, so that we can build on each other and provide services for their patients that need care that we have expertise and vice versa. Also to have a broader network to where we now cover almost the entire country. We have medical mission teams that go out into the mountain villages and have clinics. We have over 700 Guatemalan volunteers who are empowered to sit there and be in their local communities and identify patients now that we've been there so long, patients that we can serve. And they go out to the remote areas of the country and actually bring those patients to our clinics and or bring them into our main hospitals, which we work out of, which is an amazing network and organization. We've been able to build a cervical cancer screening program that started as a small program within the organization, started to branch out with some of our clinic visits as we went out into the communities, and then multiplied to where it is in every province of Guatemala, and now is funded by the government of Guatemala as well. And they partner with us in order to provide that incredible service because of the incidence of cervical cancer in the country is very, very high. So you see the network building that can really be advantageous to not only expand the mission of what you're trying to achieve, but also to create sustainability and a permanent structure that bodes well. Healthcare in every third world country, unfortunately, is one of the easiest places for people to steal money. And it becomes a great way to line your pockets if you're in a government position. And in Guatemala, the government changes every 4 years. So you're always going to be faced with that type of challenge. And having an organization that has sustainability is a way for us to overcome the politics, not only in the United States, but the politics in Guatemala as well.
Thank you. And last, Dr. Claudia.
Thank you, Sonali. I think my fellow panelists touched on all the major points, so not much left to say. But I want to add this. So in this environment, as you said, Sonali, of shrinking funding and shifting global priorities, so it's critical for NGOs to focus on what is within our control. And there is actually quite a lot. So I think it's important to double down on collaboration over competition. No single organization can meet the scale of need, but by sharing resources, aligning efforts, and co-designing programs, we can significantly increase collective impact. And Dr. Parsley touched on this. and I've seen this play out firsthand. There are moments where multiple organizations were responding to the need at the same time. And we often see this happen when there is an urgent need like disaster relief. So instead of duplicating that effort, as he mentioned, partners come together to coordinate what each could do best. So in one case, that means we focus on supplying critical medical equipment while other organizations handle staffing and local distribution. So another great example of this is a partnership we have with Build, and most recently Blessings International. So the Build is with the Texas A&M School. So they build these clinics inside containers, and they send them to us. We add the medical equipment. We furnish them with medical equipment and supplies. And most recently, we have Blessings International adding some over-the-counter medicines. So then we deploy to the final destination. So that means as soon as the clinic hits the ground, it's ready to be used. And this results in faster response, less waste, and ultimately better care for patients than if we had worked all in silos. We also need to be sharper about value and accountability. Donors or partners are looking for more measurable outcomes. This means clearly demonstrating impact, improving data collection, and being transparent about both successes and challenges. Operational efficiency is also essential. This includes optimizing supply chain, reducing waste, and exploring co-sharing models with partners. And for us, this means being very intentional about how we sort and ship supplies. It also means finding ways to do more with limited resources, whether that's consolidating shipment or working with partners to share costs and maximize reach. Another point I want to mention is the diversifying funding stream. We've all seen that relying heavily on one or two donors can create vulnerability. So NGOs should be exploring private sector partnerships, diaspora engagement, and some innovative financing model. And finally, stay close to communities you serve. We heard our keynote speaker, Major General Dustin, address this earlier. The most effective solutions come from listening and adapting to local needs, not imposing external assumptions. So if you focus on collaboration, efficiency, accountability, and community-driven approaches, we can continue to move forward, even in the most challenging environments. These are all within our control, and we get them right. If we get them right, this allow us to stretch limited resources further. So before I hand it back to you, Sonali, I want to add this. So at the end of the day, behind every shipment, every program, and every partnerships, there are people. So people like the mother who made it to the clinic just in time, or the provider who finally has the tools they need to do their job. So that's something important to keep in mind as we move forward.
Thank you. And I love that last statement, that behind all of this are people, and very beautifully expressed. I am actually going to hold on my last question because I think I shortchanged the audience last time with the last panel, so I don't want to do that again. Ronan, if you have questions from the audience, I'm going to let you take it away. And then if there's still time left, I have one last final question for our panelists, but Ronan, I'm going to give you the floor. Over to you.
Sure. Okay. Thanks, Sonali. Two questions. One, obviously, Tanya would be the best to answer, and then the other one really kind of for all of you. Someone asked, can you discuss what Medical Bridges ships beyond equipment and supplies? Do you also ship medicine? And then I think maybe just for the entire group, someone asked, what is a way in which non-medical volunteers can have an impact? What are ways, say, non-medical or kind of scientific experts can have an impact or volunteer in the different organizations or different parts of the world that you all work?
Great. So thank you, Ronan. I'll go ahead and answer the first question. So Medical bridges, there are different organizations, NGOs in the sphere we work in. So with medical bridges, we specialize on supplying medical supplies and equipment. So there are organizations that we partner with that specializes in pharmaceuticals. So medical bridges do not do pharmaceuticals. We have Blessings International, which I mentioned earlier. We have another organization called MAP. So these are partner organizations that are also accredited by the MedSurplus Alliance that, we believe are doing the process that's supposed to be done. So yes, those are organizations that do pharmaceuticals. Medical Bridges specializes in equipment and supplies.
And maybe just a quick follow-up to it, because I know the incredible work you, Walter, and all of your colleagues have done for a long time. For instance, just last week, you and I were discussing Afghanistan, obviously a catastrophically horrible scenario situation, return of the Taliban, and millions of Afghans suffering incredibly. I think it's important for people to realize not just that you work with some of those organizations. I know other organizations sometimes turn to you all to help find access, find ways to make connections in some of these difficult countries. How do you get containers or shipments into a place like Venezuela? How do you get connections to, kind of neutrally work within Afghanistan? Maybe you could just talk a little bit how you kind of are a parallel structure or a kind of a force multiplier to help some other organizations, even if you specifically are just doing equipment and supplies, right?
Correct. Yes. So we believe in collaborations, right? We are in a world where, as we said earlier, one organization cannot do it all. We do what we do best, and we rely on other organizations to use their expertise to collaborate and work more efficiently. So when we are working in areas that are hard to get in, we rely on partners on the ground. So for Afghanistan, we had served Afghanistan in the past, but in recent years, it was difficult because we have changing rules. Regulations are changing in terms of shipping. Politics is changing. So we have to be able to find a clear route before we get in. We don't want to send equipment that would stay outside of the country and not be able to get in or be discarded later on. So specifically with Afghanistan, we recently came into contact with an organization that is an Afghan organization based in the US that has that capacity. So we will meet and we do a needs assessment. We evaluate the capacity. We talk to shipping companies. And once we have a clear route, then we start to process. So we were able to ship a container last year to Afghanistan, which has arrived. So that's really how we how we work. We make sure that we are working with different entities that have the capacity and the ability to deliver the containers in country.
Great. And then, and then for all of you, kind of follow up. Obviously, financial support is incredible for any and all of your organizations, but for kind of non-medical, non-scientific people to background, without that kind of background, what are ways or ideas or suggestions you might give for those people who want to kind of give back?
I can certainly address that, and you stole the number one answer, which is fundraising. Anyone who is passionate about any of our causes can help that cause with regard to fundraising. I always remind people that people give to people. There are a lot of good causes. So those of us who are non-medical can help those medical missions by helping with the fundraising and asking for those gifts that are so important. But I think really what the heart of the question goes to is how can the non-medical people volunteer or participate in what we were talking about earlier, boots on the ground. And I would say that you can always look, at least in faith and practice, which is where I have medical mission experience directly. There are roles on teams, there are roles in organizations that are not necessarily medical. I am sure that many of you in the programs that you provide have interpreters. I am sure that many of you in the programs that you support have administrative personnel who go along with those medical providers. So there are always persons who are helping in so many different ways, even at Faith in Practice, filling out the customs form to try to help to get the equipment that you need across the border. So it's really unlimited. And I think that's the point that I want to make, that to keep an open mind and be creative, because where you have persons who are passionate about an organization, you can find a role for them. I would say the other two ways that the non-medical personnel can really help is by looking at their own network and their own career experience, whatever it is, and where can you find the partnerships and the collaborations that Tadia was just referring to. At Faith in Practice, we have an amazing corporate partnership with Zimmer Biomet, providing medical supplies to us that are in the millions of dollars annually. And that partnership was developed between two non-medical volunteers for Faith in Practice. So I think it really speaks to the ability to have an impact, even if you aren't boots on the ground in the country, providing the healthcare. Finally, I'll say that there are always roles in every organization. Every staff member that I have ever known can always use a volunteer support. And so in my experience, that's often meant joining the staff for a very short period of time. But sometimes even staff members and program employees, team members, can use a volunteer to help them with their end goal.
To add a little bit more to that too, I think these are great roles, and you have people that do logistics. We have village teams that need people just to help set up and break down clinics every day. People moving equipment and supplies around. We have warehouse people that work in our warehouses to help augment what we have as full-time employees. We have pharmacy teams that come down, and they have people that just count pills to sit there and distribute and prepare for a whole, season of medical teams coming down, and they'll put all their their medications in collectible sizes to where they can be distributed out to the teams. And then the other big area that we have is we have a partnership with a wheelchair mission out of California, and Faith in Practice, as a result, is the largest purveyor of free wheelchairs of any of the organizations that they partner with. And we bring down a number of non-medical people on several of our teams, not all of our teams, but a vast majority of them that we call our mobility team players. And they come down and they build wheelchairs. And patients come to our clinics, they get evaluated by the doctors, they get measured by our physical therapists, and the volunteers build them a wheelchair that's basically custom made for them. And for the first time in their life, they have wheels that they can move on rather than being carried by somebody in their community. It is a life-changing experience for that volunteer to sit there and see the happiness and gratitude of when they receive that wheelchair. So there's lots of different ways to get involved. The first and most important thing that I've always said is it's amazing what happens when you say yes, because there's 1,000 reasons to say no. But if you say yes, your life changes.
Absolutely. Absolutely. I really echo what Brian has just said. I completely agree. There's so many different ways you can help. Now, at Helping Hand, we have focused on building local capacity. So the way Helping Hand has worked over the years is we have many countries where we actually have our own offices. So we have our own staff members and teams across the country providing support. In many parts of and other parts of the world, we have worked with local partners. So we always have felt that from a financial perspective, it's a lot easier to be able to develop the local talent and to be able to bring in people. If there's a specific need for a specific talent, we can bring those people in, train them, and start that service there. In the point what Catherine was making earlier, I think I couldn't agree more with it. The fundraising part, what we have experimented with over the years is local clergy, imams, religious leaders who are able to kind of really see the impact on the ground and the actual work that is happening on the ground. As a result of that, we have seen big changes in terms of when people come in and they actually see what's happening on the ground and they are able to participate in some capacity. It really impacts not only the local work in that country, but it also brings a lot of information back to for example, in many of Helping Hand as an organization primarily focuses on working around, their programs are around the world, but they are doing fundraising from the different communities here in the United States. As a result of that, we are able to provide all these services to these countries. But groups of youth, for example, at college-going age, we have taken these youth groups and who are able to stay there for a week to 2 weeks, learn from what's happening, and bring that knowledge back and help with the fundraising part. Similarly, we have taken groups of professionals. I remember one time we were able to take a group of MIT students, and they found a great connection between many of the students in Jordan, in Amman, Jordan. And even after we came back, or this group came back, they were connected through the internet and they were teaching them Java classes. So lots of very interesting ways in which you can connect parts of the world to the teams here in the United States and be able to take advantage of that. So, but definitely it's worth exploring. And there are a lot of teams that have come up with very creative ways of doing this. So thank you. Obviously, Medical Bridges enabling some of this work around the world. So I want to thank them again.
So
I think we are, oh, go ahead, Tadia. And I think we're going to have to wrap up right after you're done.
Okay, so quickly to Ronan's question about the volunteer, how can we help? So in addition to everything that's being said, I just wanted to add one point, marketing. So funding is very important. Using your skills and talents the best way fits to help the organization, volunteering in warehouses, but also marketing. So spread the word to your network, sometimes even sharing a post on LinkedIn of an organization that's doing something that can reach your network, that can go a long way.
Great. Thank you very much. I think we are coming up actually a little bit past our 20-minute break. I'm going to thank all of our panelists for sharing your experiences and your wisdom, but most importantly, your perseverance and work in the world and on the front lines. Thank you very much. Walter, when do we come back? I think we come back. Sorry, I'm on Eastern time, so I think I'm an hour ahead of you.
Yeah, thanks, Sonali. By the way, you've done a great job this morning. I agree. The panelists you've talked with have been wonderful. Yes, and we're going to get back in about 12 to 14 minutes. So this is a chance to take a quick break, do an intermission. If you want to chat with somebody, don't hesitate to chat. And we'll be back just before 3:50 Central, 4:50 Eastern. I guess that's 1:50 Pacific time. And for those of you from around the world, thanks so much. We'll be back in just a few minutes. Thanks, everybody.
Great. Thank you. Thank you very, very much. Appreciate it. I'm going to take just 20 seconds. Everyone should feel free to go ahead, but just to make a plug for another global health event that will be hosted at the Baker Institute on April 21st. You can come in person or virtually. We're co-hosting it with Baylor College of Medicine and ICRC. The details are on our website, but it is about providing healthcare in conflict settings. Unfortunately, a very real issue at this moment in time. You're all welcome to come in person. We have some exciting seminars and talks and a lunch and a virtual reality session with our ICRC colleagues. We'll also have the U.S. head of MSF with us. So it's going to be a great conversation, and I hope you can make it.
I recommend it highly. I will be there also. So
yes,
hopefully you can make it in person.
If you can make it in person, you'll get a Baker lunch. So
those are always good.
Great.
Thank you.
All right, welcome back, everyone. We'll be resuming in about a minute, so please begin to make your way back. Again, thank you all for being here. This was very insightful. Continue to use the Q&A for questions and continue to use the chat. All right, welcome back. We are grateful to have you back on as we continue with the next part of the conversation. Welcome, Walter.
Well, first of all, I want to thank all of the speakers in the two prior panels and General Dusty Schultz for the opening keynote address, Sonali for the important role she's played in it. What a terrific afternoon we've already had. And that creates a certain challenge for the three case studies that we're going to go into. You know, you've heard the issues, you've heard some of the important challenges that we face as a world environment. You know, I think about the astronauts in space. I think astronaut Glover said something about this one world, one people. And they see it from up there and they see how important it is that we truly all work together. And now we have three case studies where we're actually going to dig into what's happening on the ground. The first case study is going to be reflecting the Americas, and that's the country of Guatemala. Dr. Brian Parsley and Catherine Parsley kind of did an introduction for part of what's going on in Guatemala. Then we're going to go to a case study in Eastern Europe, where we're going to be focused on Ukraine and the ambassador who has taken over the lead of Nova Ukraine. And then finally, we're going to go to the Middle East and Gaza, a place that has had terrible destruction in the last couple of years. So moving on to the first case study, and we're going to do one case study, then the next, and then we're going to open it up for questions. Thanks again to Ronan O'Malley and our friends at the World Affairs Council of Houston. It's a great place to learn about what's going on in the world. My colleague, Dr. Tadia Diallo, will be working the questions at the end when these three panelists have made their introduction. And I'm going to start with Ben. In fact, both Ben and Boris Martin have basically committed some 20 years to community and social issues and community service. Ben is the CEO of Faith in Practice. As you heard, I think Brian Parsley talk about the volunteers that serve 1,700 people in Guatemala every year. It's an amazing organization. And Ben joined them as CEO about a year and a half ago. And also, as part of this case study, is Boris Martin, like Ben, approaching 20 years in mobilizing global networks for Engineers for Good. And that's what Engineers Without Borders does. You know, Engineers Without Borders is truly globally known. A lot of it been construction projects, a lot of it been water projects. It's kind of where something needs to be built, where engineers can create critical infrastructure. And recently, Engineers Without Borders acquired a small nonprofit called Engineering World Health, and their focus was exclusively on biomed tech work in the developing world, a place where the best work that someone like Medical Bridges can do doesn't live its full lifespan. And Boris has done a great job integrating that into Engineers Without Borders and focusing on creating better health. So what a great way to start the case studies. Ben, maybe we'd start with you. And what do you see as the situation on the ground in Guatemala?
Yeah, first I'd like to just say thank you, Walter, Lydia, Tadia, Sonali, and the entire Medical Bridges staff for convening this very important global health conversation. You know, you'll notice in the image of my background here, there's sort of volcanoes in the background there. That's not accidental. You know, Guatemala, just like many of the other countries we've talked about here today, is a land of breathtaking beauty, but also constant tension. those volcanoes are both majestic and very, very active, right? But they represent something deeper about the communities we serve, which is resilience in the face of instability. And in many ways, that's what global health looks like on the ground in Guatemala today. Beauty, complexity, and ongoing challenges sort of all at once. So for us at Faith and Practice, just really quickly, our mission is to improve the health and wellness of underserved Guatemalans. And we do that from four basic components. You've heard a lot from the Parsleys about our medical mission components. The second part of what we do is community-based health initiatives and also robust partnerships, which is what we'll mainly spend our time talking about today. And lastly, through education. So pivoting back to the situation on ground currently in the country of Guatemala, there's a significant shortage of effective equipment. And not just that, it's also being able to procure the equipment and maintain the equipment. In addition to that, finding individuals who have the educational capacity to utilize that equipment.
Excellent, excellent. And now I'm going to move to Boris, but before I do, I see Barbara Grinnell is in attendance today. And you heard Catherine Parsley talk about you don't have to be a doctor or a nurse to make a difference. I got to know Boris because Barbara Grinnell recognized the power of what he was doing and saw the fit with Medical Bridges. And so, Barbara will dedicate this particular case study to you. Boris, talk a little bit about your situation in Guatemala.
Nice. Thanks a lot for having me. It's a real pleasure to be joining all of you during this event and to share a little bit about Engineers Without Borders work in Guatemala. I did have a few visuals. Can I share my screen? Is that okay? Or
I think just chat about it.
Just chat about it. Fantastic. Okay, so Engineers Without Borders USA is a 25-year-old organization that has mobilized volunteers, professional engineers, and students of engineering for 25 years to volunteer their skills and improve the well-being of communities around the world. And as Walter said, more recently, we have gone from being a uniquely kind of community infrastructure focused organization, like the brick and mortar of water systems, of resilient school buildings, of solarization of healthcare facilities. We've really started focusing on community health as a holistic challenge. So we have if you go to a healthcare facility in Guatemala, you have for 1 in 10 of them may not have any electricity at all. About 30% of them may have somewhat reliable electricity, and about 20 to 30% of them may not have clean water at the tap. And really, this was Engineers Without Borders' entry into the world of improving healthcare facilities. It was through the infrastructure of on the building, solar panels on the building, clean water at the tap, which are really essential services for any healthcare facility. But very quickly, we realized that if you walk at the back of a healthcare facility, in almost 100% of the cases, you will have what we call an equipment graveyard. A lot of donated equipment that's been piled at the back, frankly, because it's useful for spare parts oftentimes, but simply not being utilized because it's really come to the end of its life, often prematurely. In an ironic way, we even discovered that the unstable electricity on the building was oftentimes causing the machines to break because power surges are really bad for electronic equipment. And that's why over the past few years, we've basically established, and through the sort of the merger with Engineering World Health, inherited a very sophisticated program of training of biomedical technicians on site so that people have the tools and the know-how and frankly, access also to the repair manuals, which are often really hard to find because they're protected by the manufacturers in order to be able to repair the pieces of equipment that they, are often donated by, partners like Medical Bridges and others. And so we have, come to understand ourselves as a sort of a technical partner to extend the life and to extend the impact of partner organizations that are in the business of supporting healthcare systems, donating equipment. And so this is kind of how the connection with Medical Bridges was done. Barbara, thank you again for introducing us, because we do add value, but we can't do that work on our own. It really is through partnership. So yeah, that's a little bit about us.
Of course, that's perfect. I hope everybody is beginning to understand, Ben and Faith in Practice does an amazing job sending doctors like Dr. Parsley, volunteers like his wife, Catherine, into Guatemala to treat people. And they have a couple of flagship places they return to over and over again, so it's sustainable. Medical Bridges is able to provide high quality surplus medical equipment. You heard Dr. Tadia talk about that earlier at two places like Guatemala. But we share the challenge that Boris specifically mentioned, that we might have, there might be a piece of equipment with a 12-year life that is in great shape there, but after 4 years, the local hospital now is upgrades to something with the next bell or whistle, and we send it to Guatemala. And whether it's a power problem or the person who's the biomed tech is the same person who cleans the gutters and sweeps the stoop, after 18 months, rather than lasting 8 years, it fails. That means for an organization like Medical Bridges, we could send something 4 times, or maybe we could keep it alive. Ben, would you talk a little bit about this collaboration that we're planning for the third quarter?
Yes, I would love to. So, just as powerful as our volunteers, who are really the lifeline of our mission, so is just partnerships for us. And specifically, this partnership with Engineers Without Borders and Medical Bridges represents a shift for us from just doing good work to really great alignment. As Walter mentioned, Medical Bridges brings, very high quality refurbished medical equipment. Engineers Without Borders ensures installation, training, and long-term maintenance is being done. And then we obviously, ensure that the equipment is placed in the right facilities with the right relationships in the right regions. Each organization brings a very distinct strength, but together we create something far more powerful than any of us could do alone. For Faith in Practice, this partnership is really a critical evolution. Again, it sort of transforms us from just delivering care to really strengthening systems that deliver care. So for me, the questions we now ask are things like instead of asking how many patients can we see each week, we're now moving to asking questions like, how do we ensure patients are cared for year round, even when our volunteers are not there? So what that means is, being able to expand our diagnostic capabilities within local hospitals, increasing surgical safety and efficiency, and really enabling the local providers to serve more patients more effectively when we're not around. And that's how we build capacity, not dependency.
Boris, I mean, what you're doing as part of this collaboration is to exactly make that same thing possible.
Yeah, that's correct. I mean, we, and in Guatemala specifically, we had already in the plans of with a different partner to run what we call sort of equipment repair institutes, where we mobilize volunteers to be embedded within the healthcare facilities, and we identified 6 different cities where we'll basically provide these repair services. And it happens that there's a couple of them that actually completely align with the places where Faith in Practice is already doing work. And so there's always an opportunity to get started on the shoestring, and to do things where we're in the same place. I think we're still working on the timing of the visits to make sure that that everything is coordinated well. But for me, it's also like the backbone of partnership in the long term is when we together kind of organize and structure our approach and our shared vision and honestly find resources behind it, because it's an important aspect of the equation, isn't it?
It is indeed. It's interesting because each of our organizations many years ago started with a small step, and now this collaboration is a small step. But I believe, Boris, that this can be a model for not only Guatemala, but for the 107 countries where Medical Bridges provides advice. Now, I'm going to ask the two of you to stand by because we're going to go to the next case study, but we will have you back for the Q&A in about 25 minutes. So stand by, and we are now ready to move on to the Ukraine situation. And what a honor and delight to be able to invite and introduce Ambassador Erin McKee. She's currently the CEO.
They're right there in the corner.
Hmm?
There's one time, but you need every week, every 2 weeks.
Walter, you need to unmute. There you
Yes,
go.
I think you and I are finally unmuted. Let's start this one more time. Ambassador McKee is currently the CEO of Nova Ukraine. Her service with our country began 30 years ago when she joined USAID. She had several foreign aid assignments. She worked with them and then worked with some other organizations until 2019, when she was named ambassador for Papua New Guinea, Solomon Islands, and Vanuatu, and I probably pronounced the last one wrong. And then she returned to USAID, and after that, accepted leadership of Nova Ukraine. Nova Ukraine is one of the most important organizations supporting Ukraine and its people, with the ultimate goal of a strong, flourishing nation. Nova Ukraine, listen to this, has helped 12 million people in Ukraine, a country that's been at war now for 4 years and 2 months. Ambassador, please describe the situation in Ukraine as you see it, how Nova Ukraine is helping the people of Ukraine, and what you consider to be the best practices.
Walter, thank you so much, and good afternoon. Thank you for the opportunity to speak with all of you today and to be part of this distinguished panel. To describe the current situation in Ukraine, I'd like to begin by sharing my personal experience. During my visit in November last year, I spent the majority of my nights in bomb shelters because of the Russian shelling. On November 19th, a day that I will never forget, Russia launched over 476 drones and 48 ballistic missiles targeting civilian infrastructure on that night. 31 people were killed, civilians, and dozens of buildings, including our medical aid warehouse in Lviv, were destroyed. Fortunately, of course, none of our team members were injured, but the material losses were significant. The warehouse primarily stored equipment like ultrasound systems, surgical instruments, vital medical supplies for over 600 medical institutions, clinics, and hospitals in the Ukraine regions, many of them closest to the front lines. And everything was destroyed in an instant. And so I walked through the charred rubble the day after the shelling, and there really are no words for what it feels like to stand amongst the ashes of equipment that is meant to save lives. But I need to, for the broader group, share that, that was sort of a personal devastating loss, but it was no accident. Russia has struck the UN World Food Programme's warehouse in Dnipro, humanitarian warehouses in Kherson, Zaporizhia, dozens of other places. To be clear, this is the textbook definition of war crimes. So what are we doing to restore medical care? Well, first, in the case of our warehouse, we had 3 replacement containers already in transit that were due to arrive within days of its destruction. And we were able to, with help of partners, and I heard my colleagues mention the power of partnership and how important it is in their presentation, and I cannot reiterate that enough. We were able to reroute, restock, and store and not lose a beat immediately. But logistics in Ukraine, as they are all over the world, but in Ukraine with the closed airspace, it's challenging, slow, and costly. And deliveries rely on complex ground routes, and assembling shipments is difficult. And so what we do, our approach to respond to the most critical needs, or is to basically tackle the most critical needs first. And we work directly with hospitals to verify each request for aid, assess their resources. I heard capacity. Capacity is always a challenge, and to make sure that we aren't providing something that won't be used or runs out of spare parts or the commodities that are necessary to keep it going right away. And one of our features is proximity to the front line, because we have to prioritize those in country who cannot operate without support. But our vision as an organization, you said, sort of what are we doing, goes beyond the short term. Saving lives is paramount. But we recognize the importance not only of saving lives, but improving the health system as we do so. Our approach is not a handout, but a hand up, and using the generosity of our partners and our donors to make sure that Ukraine has what they need to be able to save their people, improve their system, build that capacity to ensure that those relentless attacks are not successful, and that they don't take out the heart of the country, which is its people. So our approach is to leverage emergency response into longer term recovery and renewal. So with every investment, we work with our partners to make a modern, sustainable healthcare system. And I'd like to stress, as I said before, that Ukraine does not need saving from the outside. It needs visionary partners who invest with Ukraine in its systems, in its endurance, and its people to succeed over the long term. Walter, you mentioned that we're in 4 years and 2 months of this war. If you all recall, everyone thought on February 24th that it would be over in a matter of days. That clearly, we've all collectively, the entire free world, but most importantly, Ukraine, have proved Putin wrong, and that was not successful. But with that time also comes challenges with keeping Ukraine on the minds of donors, on the minds of partners, because we've got to keep that sustained support going. And our medical work, in particular, falls under our HEAL pillar, which is back to immediate response to longer term recovery. It's guided by the vision that Ukraine should have and deserves a modernized, accessible healthcare system with the capacity to save lives and deliver quality European standard care for their communities. So our work right now today covers the full spectrum of healthcare in Ukraine. Emergency response, we provided trauma care training that's reached over 10,000 people in 2025 alone. Approximately 70 stabilization points, which are the immediate life-saving medical stabilization points for wounded, both civilians and combatants, where they are triaged and then obviously referred to where the next point of care is required. For hospitals, we deliver medicines, equipment, oncology drugs. Last year, we met more than 220 hospitals' requests across 15 regions. And diagnostics, we've talked a lot about equipment. We heard our colleagues say, that electricity can degrade the really important life-saving medical equipment that is so needed. And that is so true for Ukraine as well, not because of volcanic eruptions or the deterioration or lack of maturity of the infrastructure. It's because Putin's targeting civilian infrastructure and the power grid on a daily basis. And so we look at sustaining that equipment and making sure that the electric supply is diversified and renewable, so that once we deliver commodities, equipment, diagnostic machines, they can be in use even when they're under active shelling. We, for example, 75 portable ultrasound units and mobile X-ray systems for frontline use. $2 million in medical supply chain commodities were also delivered in 2025, which has a value multiplier of over 17 times. All of this is with an eye towards not just providing the immediate help, but providing sustained help over time. And that brings me to Medical Bridges, which is our largest in-kind donor. And since the start of the war, thank you, thank you, thank you. You've provided over 10 million to help Nova Ukraine deliver large scale, 10 million valued, large scale medical aid, including 10 massive containers of equipment in 2025 alone. And for everybody listening, this isn't just for those wounded in combat. We need continuity of care as well. We have Ukrainian patients from newborns to the elderly to chronically ill, in addition to obviously the horrors wrought by the reign of terror from Russia. So just to wrap up, one of the best ways to illustrate our approach of working on systems level change while solving the problem in the moment is an initiative that we call Ukraine Without Pain. And it's a national level effort to address the growing chronic pain crisis. We created this initiative in partnership with the Ministry of Health to advance chronic pain treatment. The scale of the problem is significant. Trauma-related injuries and amputations have risen sharply during the war, and pain remains widely undiagnosed and undertreated, or the treatment is standard pharmacological, which, as we know, has horrific potential side effects, including long-term addiction. And so we have today, after the initiative was launched last year, we've established 11 centers, 155 specialists have been trained, and more than 10,000 patients have been supported. I just want to share with you one of the most heartwarming elements of this. I watched this initiative in action. I went to a hospital in Kyiv a few months ago, and I met a veteran there, an amputee, who after treatment and the new approach to pain management, he overcame his chronic pain and climbed Hoverla, which is the highest mountain in Ukraine. That demonstrates the fortitude, the courage, and the determination of the Ukrainian people that we've seen over the last 4+ years. So early in the war, closing lessons, you'd asked me, Walter, to mention something, sort of what we've learned in our journey, at least as an organization and working in this sector. And in 2022, everybody was all in. Oh my gosh, we can't believe this has happened. Full-scale invasion. We want to help. We want to help. We want to help. And we received large volumes of donated medical equipment, neonatal, maternity beds, other supplies. It was fantastic. And we accepted almost everything that was offered and distributed it directly to hospitals. And while well-intentioned, this approach actually led to real challenges. Some equipment was not fully functional or appropriate for local use. And that created reputational risks and additional resources from us to repair, replace, return items, or make them fit for purpose. And so we learned quickly from this, and we operate it at much more structured. We make sure that what we deliver is fit for purpose, functional. The commodities necessary to keep it going are also in acute supply. And back to the electricity problem, we make sure that there is a consistent, sustained source of electricity so that none of the hospitals, none of the stability centers, and none of the clinics go dark when it matters the most. So to conclude, I would say that we've learned from our HEAL pillar tremendous amount. And for this audience in particular, I hope you'll appreciate a couple of the lessons. I'm sure they'll resonate. One, continuum of care is essential rather than isolated interventions. One-off interventions fall short, and impact comes from linking emergency response to long-term recovery in a seamless chain. Speed and systems must coexist. Urgency matters, but without structure, even the fastest response fails to deliver at scale. And health systems gaps that we see in countries where we all work, they expand during conflict. So war doesn't just strain care, it exposes and accelerates existing weaknesses. Recovery starts during the crisis, not after. Waiting for stability delays progress. Rebuilding must start even while the emergency is unfolding. And lastly, nonprofits, organizations like ours, can fill critical gaps where the state lacks the capacity to respond, but you can't do it in isolation. We are stronger together, and it's important for us to remember as we see resources, crises, and the world, frankly, on fire, resources diminishing, crises expanding, that the more that we can do together and leverage each other's greatest core capabilities, the better difference, the more lives we'll save, and the better long-term outcome we will see. So thank you, Walter, for having me, and it's an honor to represent Nova Ukraine, and I'm grateful to Medical Bridges for the lasting impact that we have been able to have in partnership with the Ukrainian people.
I think everybody can see how you brought that 30 years of experience helping people around the world to the people of Ukraine, who are not only fighting for their freedom, in my opinion, they're fighting for my freedom, my daughter's and her husband's freedom, and my grandson's freedom. So stand by. We're going to do one more case study and then come back for Q&A. That was absolutely terrific. And now to move on to the situation in Gaza. And again, another privileged guest today is Dholuo, President and COO of the International Medical Corps. We'll take one moment, if you don't mind, away from this very important topic. There's a little school you may know something about that won some minor basketball game last night after crushing Arizona a couple nights before.
Well, thank you for that, Walter. And yes, our entire family is just thrilled right now. I mean, and thank you for your support. So go blue.
Yeah, I can see you're even wearing a blue jacket today.
Yes.
Let me tell you all a little bit about Key. He was involved with the International Medical Corps as early as 2003, spent time with USAID. He served on several councils, most internationally focused, but some also for New Orleans. He returned to the International Medical Corps 9 years ago. He has been instrumental in helping IMC save lives and relieve suffering in some 28 of the most desperate countries in the world, where they focus on healthcare services and training, often in difficult and not uncommonly dangerous environments. A really, really difficult, you go where it's hard, Key. Let's start, though, with kind of an overview of the situation as you see it in Gaza.
Walter, thank you for that question. I'll start with the health system pre-October 7, 2023, which already was quite fragile. Most of the facilities in Gaza prior to October 7th was already suffering from fuel shortages, staffing shortages. The blockade was creating challenges in terms of the supply chain. There were approximately, I think, 36 hospitals that were operating with about 3,400 beds. Now, that's serving about 2 million people in Gaza. So that's approximately 1.4 beds per 1,000 population, which is way beneath the global average of 2.9 per 1,000. So the system itself already had major gaps and faced many, many challenges. The conflict over the last 2+ years has decimated the health system. I wouldn't even call it health system. It's at this point in time, it's barely functioning, highly damaged facilities that are operating with whatever resources they have. So even though we are now in a sustained ceasefire since October of 2025, we're facing severe shortages and challenges, and the recent conflict in Iran has also now created great shortages in the markets. We've seen skyrocketing prices in terms of just food stocks, And we're starting to see now pockets of malnutrition again show up throughout Gaza. So the situation, as I said here, in terms of access for the civilian population was already operating at a gap. Now, during the conflict, and especially during the early days of the conflict in Gaza, as you all remember, within weeks of October 7th, over 1 million people who were living in the north of Gaza were under mandatory evacuation. 1.2 million people at that time were living in the north, which is really where most of the hospitals and primary healthcare centers were situated. So overnight, you had 1 million people who were displaced, moving towards the middle area. And then at some point in time in the spring of 2024, this entire population, almost 2 million people, were pushed down into the south near the Rafah border, which did not have a single tertiary hospital at that stage. So you can think through in terms of the devastation, destruction of the conflict in terms of the infrastructure itself, but also access issues, just because people were on the move constantly, and either they had no access to be able to reach a hospital, or the hospital was greatly damaged and not functioning. So it's really within kind of that context that International Medical Corps really changed our strategy, because prior to October 7th, we had been operating in Gaza, but primarily more of a development program, focusing on capacity building, strengthening the emergency preparedness and response capacity. We had some direct delivery of services in terms of mental health and psychosocial services, but we quickly realized that with the movement of the population, the targeting of health facilities, that field hospitals would be greatly needed. So it was really right around, I think, the late fall of 2023, and in partnership with Sonali. She was instrumental at that time at USAID in terms of bouncing around the idea of supporting International Medical Corps, both in terms of engaging with the Israelis, in terms of coordinating, in terms of providing resources through USAID. So really, without the U.S. government support, we would not have been able to do what we did and have accomplished over this period of time.
So you mentioned field hospital. What does a field hospital look like? How big is it? What does it entail? I know you have volunteer physicians and mostly paid physicians as well. Tell us about, many of us watched Pitt on TV, right? So tell us about the hospitals themselves.
So the field hospital idea started initially with the kind of a capacity where we were going to have a 50-bed hospital, and this started, as I said, right in the fall of 2023, and we had prefabs, we had containers that were in our facilities and warehouses in partnership with FedEx, where we store many of our emergency response stockpiles. So we loaded up these containers, and they come fully equipped, operating theaters, with beds, with equipment, with medicines for 3 months. And I will say that it was a miracle that we were able to bring in almost all of these containers in the end of December. So when I look back in terms of the timeline, the first field hospital that we started in Gaza, we set up, the containers arrived on January 3rd, and our team of logisticians and clinicians were able to set up this field hospital. It's a 50-bed hospital, 2 operating theaters. Within 3 days, we became operational. We were expecting to see maybe 100 patients per day, which is what it was set up to do. We were seeing upwards of 1,000 patients per day. This field hospital was set up initially along the border in the middle area of Rafah and Khan Yunis, along that border. And this is really where 1.5 million people were pushed from the north down. So our hospital immediately became the major referral point from January to about April. And at that stage, which is really where the population then was pushed down into the south. Now, why are field hospitals relevant within this context? Because static facilities, you can't move them. They're under attack. So when it became clear that the population was moving down south, we actually moved that initial field hospital along the border of Khan Yunis with 150 patients. We moved them down to Rafah and had continuous operations. So that first field hospital moved to the south and became the major referral hospital in all of the south for the 2 million people who were displaced at that time. We then set up a second field hospital and a third field hospital in the middle area. And now we have are operating 3 full field hospitals, 2 in the middle area, 1 in Gaza City. The bed capacity right now is about anywhere from 350 to 400 beds. We're seeing about 4,000 patients per day. Over the last, since January 2024, these field hospitals have provided upwards of 800,000 consultations. As I said, we continue to see 4,000 patients per day in our outpatient. We carry out 50 major surgeries per day still. One incredible number here is that when we look back at it, that I think upwards of 30% of all newborns since January 2024, 30% of all newborns were safely delivered in our facilities. So these 3 field hospitals played an instrumental role during the height of the conflict, and they're continuing to play a role in the ceasefire because 90% of the health facilities in Gaza were damaged. Maybe 50% of the hospitals are partially functioning at this stage. So the field hospitals continue to serve in the front lines in terms of where the population movement is. And I will tell you that, I've been doing this work since, I guess probably since 1991 with the conflict in the former Yugoslavia. I've worked on every major disaster since then: Afghanistan, the Caucasus, Iraq, South Sudan. I'll tell you that this has been the most complex and most challenging and most personal conflict and response I've ever worked on. We have upwards of 1,500 staff currently within the 3 field hospitals. There's not a single staff member in these facilities that have not lost a son, a daughter, a parent, a sibling, a wife, a husband. It is at that nature within which our staff, who themselves have been displaced over and over and over again. And it's amazing the commitment that they have to be able to, on a daily basis, they are living in IDP, internally displaced camps, in and around the hospital themselves. Back in August and July of 2025, where food was not getting into Gaza whatsoever, and we had IPC levels of 5, famine was declared in major parts of Gaza. In our field hospitals, we were seeing really alarming rates here, where malnutrition rates at 50% among pregnant and lactating women, malnutrition rates over 20% among children under 5. Even worse than that, children ages 5 to 18, we saw malnutrition rates around 48%. Our staff themselves were living under those same situations. We had people who arrived, were fainting because they did not have enough food. So this is the program. I mean, I look back upon what our staff were able to do. I look back in terms of what we're currently doing. I had the opportunity throughout the last couple of years to go and work within the hospitals themselves. I was in that first field hospital in February and March at the height of the conflict. And I can tell you it's been the most rewarding experience of my life. And just to be able to work with professionals, with people who are so committed to being able to carry out our mission. It's been quite a miracle in terms of what we've been able to accomplish in Gaza.
What a remarkable story, but a remarkable competency in advancing something of the heart. Congratulations.
Thank you.
With that, we're going to bring all the speakers for the case study back up on the screen, along with Dr. Diallo, who is going to help sort through one or two questions. This is just amazing. And while everybody's being brought back, one of the things that I've observed in the case studies, these 3 case studies, is yes, there's the passion and there's the heart. But kind of paraphrasing a song, I Will Wait for You by Mumford and Sons, I will use my head alongside my heart, right? These are organizations that are extremely professionally, competently run and managed. The missions that they do in difficult places around the world are just absolutely stunning. They are absolutely incredible missions. And so it takes a lot more than just having heart. And so it takes not only the competency, but it takes the discipline under those circumstances. And I think the last point that comes from all of these is thoughtfulness. How can you serve in a thoughtful way, using best practices and not interfering with other things that might be going on that might have different priorities? I think that Toddy, I might give you the first question, and then I'm going to follow up with a question. So go ahead, Dr. Diallo.
Sounds good, Walter. Thank you. And thank you to our panelists for sharing your insights today. This has been a great conversation on such important topic, and your real-world experience and examples really bring to life the impact of partnerships and collaborations in global health. So it looks like we have a quiet moment in the chat, so I'll go ahead and start with this question. Across your work in Guatemala, Ukraine, and Gaza, partnerships often bring together NGOs, government, and local communities. So what has been the most critical factor in building trust among partners on the ground? And how has that trust directly influenced patient outcomes?
Ambassador, do you want to go first?
Sure. So building trust is vital, but building that trust is through delivered impact and competency, right? We can say the most beautiful words in the world, but if we don't listen to the true needs and then respond in that moment, that's the opportunity to be able to demonstrate that you're there, that you heard, that you understand, and that you can execute with impact. And so I would basically underscore the importance of absolutely understanding what the needs are, understanding where some of the pitfalls are around delivering those needs, whether it's electricity supply, capacity, commodities or consumables associated, particularly with really important life-saving equipment, and be prepared to respond in the moment. That's the expectation, and that sets the foundation for then a long-term partnership and engagement.
Ambassador, you used the word listening, which is a great tie back to General Dusty Schultz, because she made the emphasis as well that it's important to really listen, to hear, to understand and process. So well said. But Boris, how would you respond to Tadia's question?
I think the word that would volunteer is respect. Respecting partners means being very clear with what you can deliver and what you cannot deliver. It means focusing on execution and going all the way through, following through with commitments. That earns trust. But it's also about self-respect. It's understanding what you expect from the partners and making sure that that is also articulated. It's a way to respect a partner, to be clear with them as to like what they are expected to bring to the table as well. And this is, partners at every level. Local governments, national governments can also overpromise sometimes and underdeliver. And so having really serious conversations and helping people be accountable at all levels, including yourself, I think is a really, like in my experience, has been a strong driver of trust in the partnerships.
When you talk about that, you're also talking about a certain candor, aren't you, Boris?
Yeah, and transparency, right? And the courage to also be transparent with your mistakes, miss deadlines if they happen. I mean, it's in the name of a partnership, you cannot just like, keep things in the shadows. You have to bring everything to the fore.
Perfect. And Ben, your thoughts on this?
Yeah, that's a great question. Because partnerships, obviously, while they're powerful, they're not automatic. Certainly agree with everything Boris has already mentioned. I believe the most effective partnerships happen when we sort of shift our mindsets from what can each organization contribute to rather where are we already aligned in purpose and how do we problem solve together? And one approach I think Faith and Practice and Engineers Without Borders and Medical Bridges sort of initially from the onset looked at was honestly how our operational pain points align, whether that's equipment access, infrastructure gaps, or even logistics. I think early on we were able to identify how our partnerships ultimately improved our different organizational strengths and how we could address those gaps that we each have.
And key, yeah, the question of trust, I think of all the constituencies you have to deal with. You have to deal with communities and the people you serve. You have to deal with the people of Gaza. You have to deal with Israel. You have to deal with your donors. There's so many parts.
Yeah.
How do you, and some of those different parts aren't always in agreement with one another. How do you build that trust?
As I said, I mean, I think Gaza has been the most complex mission I've ever worked on. And you've laid that out in terms of the various actors and the need to constantly find common ground and find the right approach in order to be able to get access, to be able to bring in our supplies, in order to ensure stability and safety and security of our staff and the people who walk in to our field hospitals. I would say that, of course, in terms of partnerships, we aspire to be good partners. We work with local partners, international partners, governmental partners. But I would say that more often than not, in some of the settings we work globally, there is a competition among partners in terms of accessing resources. Gaza is unique in the sense that I've never seen collaboration at this level. It is as if we're all facing the same challenges. And I will say that, I'll put it out there. I mean, sometimes we compete, for example, with Médecins Sans Frontières. In Gaza, they opened up their warehouses, their stocks to us, because the role that our field hospitals were playing, and especially in terms of the major referral trauma points, if we did not have essential medicines, people were going to die. WHO did the same thing, ICRC. So when we were facing stockouts, when we were challenged in terms of getting fuel, it was a collaboration and a spirit where we were all focused on one thing, which was to be able to have business continuity to make sure that these field hospitals continue to play the role that they serve within the front lines. So I think, as I said, I've never worked on anything like Gaza. It has been the most rewarding experience. And across the board, the collaboration at all levels has allowed us to be able to do what we're doing. So it's pretty unique. It's challenging, but very unique.
Before I go back to Tadia for the next question, I want to comment on something you said. I mean, throughout this afternoon, we've had extraordinary people that are leaders, and Key, you're absolutely no exception. You're actually a terrific example of global humanitarian leadership. And yet you say, I aspire to be a good partner. I think that humility is part of what makes the organizations that are on this panel, these case studies, as successful as they are. That humility means they are doing what we just talked about 2 minutes ago. That means they're listening, they're hearing, they're learning, they're being transparent, they're being candid, they're building trust. I love it. Tati, I think we'll have one more question from your end, and then I have a closing question.
Sounds good. We have a question for Dr. Kilu. This is from Ariana Marashi. who said, "Thank you for sharing the work of IMC and strong efforts in Gaza. It is incredible to hear everything the organization is doing and the deep commitment to this population. What do negotiations look like with Israeli authorities to allow the movement of humanitarian medical aid with IMC? And how have these conversations changed since October 2023?
So I think we've been very fortunate, especially, if you're familiar with our work globally, we're not that vocal, we're not that visible. It's our work that speaks at that field level. And I think that that's the approach that we took with the civilian coordination authorities, COGAT, within Israel and Gaza, that it was clear in terms of our mission and our mandate. I'll say it's not been easy to it's not that we look the other way, but the reality is that we allow the work to speak for itself, and that I think has allowed a clarity in terms of our mission, and therefore we are seen as a neutral, independent actor within Gaza, and that has allowed us, both with the Israelis as well as the authorities, the de facto authorities within Gaza, that views us and the work that we do, and that they actually are vested in the ability for us to have been maintaining our business continuity throughout this conflict. It hasn't been easy because we operate under the same rules. I mean, the challenge in terms of dual use, if you're familiar in terms of what can come in to Israel, anything that can be potentially used by Hamas, for example, for their efforts was denied. It's not that simple, because even, let's say, bringing in a tent, a metal pole was considered to be dual use. So it required daily, weekly communication. And even sometimes we would have approvals, and it would get to the border, and then somebody says, no, you don't have that. And then you have to restart the process. So we were very clear up front in terms of, we establish our logistical and supply chain capacity. We had it through our offices in Amman. We had offices in the West Bank. We had offices in Egypt. And we really took it upon ourselves to manage our logistics. And therefore, when we were communicating with the authorities, we were communicating with them directly and not going through an intermediary. And that really helped. And we were, as well as, fortunate. Once we got our supplies inside Gaza, we did not suffer any major looting events, because they recognized that these were International Medical Corps supplies and equipment are coming in. We had one event in terms of a couple trucks that were looted, and then within days, the supplies were brought back to our field hospital. So again, I think it's the ability to be able to have transparent communication, and to be seen in terms of the work and the mission, and that really has allowed us to be able to do what we're doing.
Key, your example is kind of the most advanced postgraduate course in complexity. Yes, there are absolutely complexities in Ukraine. There are complexities in Guatemala. There are complexities of providing humanitarian efforts in every developing world and every country that is at war or has civil unrest. There are difficulties. Surprisingly, for medical bridges, one of the hardest countries for us to get into happens to be Mexico because of the bureaucracy, right? But Key, your example really speaks about kind of the most difficult case, but something that for all the audience to know is something that, all the organizations that have talked today see to one level or another. I've got one other quick question. I think it's a really important one. Well, first, let me say this. I know that all of you get great satisfaction from your work. I know that. But the question I have for you is, if you were to offer one point to the other people that are participating about humanitarian efforts in health, what would be that one suggestion or point that you might make? And maybe we'll start with Boris. We'll go to Ben, Key, and let Aaron close that, and then I'll close the event with a few personal remarks. Boris, why don't you start us off?
So you said make a suggestion to others, or like pick a.
Thank you for asking me to clarify. Boris, what I'm thinking about is what would be the one thing you would like other people attending to be left with as we close this event?
Oh, nice. Well, thanks for that. Thanks for that question. I was really taken by the point Aaron made about the importance of continuity and commitment. And obviously the aggression of Russia and Ukraine is kind of a very specific, violent event. And but I think that lesson applies everywhere. It takes long-term commitment to get anything done in the world, and so I really thought I would highlight that lesson.
Right. Thanks. Ben, how about you?
Yeah, I guess I'll close with this. Kind of like I said in the beginning, the first question, just like the volcanoes you all see in the background here that I have of Guatemala, the challenges we face in global health are real. They're ongoing and sometimes very unpredictable, but so is the resilience of the people we serve. And when organizations like everybody here comes together with alignment, humility, as you mentioned, Walter, and purpose, we don't just respond to need, we help reshape what's really possible. And we begin to see something extraordinary, not just care delivered, but systems that are strengthened, communities that are empowered, and lives that are restored fully and holistically. And as a person who, over 30 years ago was in an area that needed medical missionaries to come save my life, I know how important this work is. So I encourage you all, as Dr. Parsley said, continue to say yes, and God will continue to bless you and ensure that while it'll still be challenging, our roads will be a little bit more paved. So thank you all.
Thank you, Ben and Key.
Well, I mean, it's a lot has already been said here, and I fully support it. I listened to some of the earlier panels, and I think, having lived through the past year, our community is facing major challenges, and it's not just resources; it's just, the way within which we go about our work has changed forever, and that does require us to look for new solutions. And I think that focusing on the people that we serve will give us the strength to be able to find that innovation, because trying to go back to the old system, that's done. Okay, I think we can reflect upon what worked and what didn't work, but the reality here is that it's a whole new world within our kind of humanitarian community. I believe we're up to that challenge. And as long as we stay focused, again, on the people who need us the most, we will find that strength.
We have no choice than to be up to the challenge. Ambassador.
I'd like to say what you opened with, Walter, and that is at the core of the word humanitarian is the word human, and that we are all in this endeavor to save or improve the lives of others. And that passion, even though it's getting harder, as you pointed out, Key, that drive, that passion, and being able to make a difference, whether it's one person, one community, one country, or ultimately the whole planet, it matters. And it matters. Ben, as you mentioned, it saved your life, that response and that capability. Don't let go of what you do, because it matters. As John F. Kennedy said when he founded USAID back in 1961, he said, "We are all humans. We all share this small planet."
We all have shared this moment. Many thanks to this panel, Boris, Ben, Key, Aaron, and Tadia for bringing in some questions I'm going to spend just a couple minutes to wrap up. You heard when we started that Akini said something about us being together and building connections. Sonali reminded us of the reduction of foreign aid and the importance of NGOs and individuals. We just talked about trust in this panel, but Dusty made a point that there are numerous catastrophes. There's great healthcare available, but we're not matching them up, and that we need to have trust and a bias for action. Andrew talked about the disruptions in child and maternal health. Dr. Hotez talked about the difficult times. He talked about the threat of polio coming back. I'm of the age when I remember when there was polio and iron lungs, and I had a friend who had polio at the time. And Dr. John emphasized the importance of community. And Dr. John also made the point that the work we do cannot be transactional. And Andrew reiterated there has to be local ownership and pointed out countries with rich governments like Ethiopia with a long culture and countries that have no governments like Sudan. Tadia in the panel that she was on initially was about fit for purpose. And Javed talked about the number of countries, Brian about sustainability. And this is important. Catherine Parsley talked about how you didn't need to be a physician to be able to make a difference while all of that was going on. And then we also heard about the importance of collaboration by several of you did that. Importance about partnership on the panel we just finished and how partnerships can strengthen the system. Boris talked about the word mobilization, making things happen. And of course, all of the panelists on this last panel have mobilized life-saving humanitarian efforts around the world. The continuous conversation about partnerships, continuity, commitment, and resilience, very, very important. If you were to ask me 2 years ago, what was the status of global health? I would have said to you that there are 4.5 billion people in the world without adequate health care. If you ask me that question today, I'd say there are 4.5 billion people without adequate health care, and 4 million more of them are going to die. The situation in the countries we've heard about, Guatemala is a poor country, it's desperate. Haiti, was mentioned many times, that is another poor country with desperation. In Ukraine, as many as 3,000 healthcare hospitals, clinics, and capabilities have been attacked, including 3 maternity hospitals, one relatively recently, including their largest children's hospital in Houston. We think of Texas Children's. Their Texas Children's Hospital was attacked and bombed. This is a society where more and more people are being injured, where people, in addition to the routine health care, and yes, there are less and less capabilities for dealing with it. You heard Key talk about how few operating beds and the huge impact, life-saving impact that the field hospitals are happening. In some countries, and I think Sudan, which was mentioned, Cote d'Ivoire may be another example, out of every 100 live births, not 1,000, not 10,000, but out of every 100 live births, 6 babies and 1 or 2 mommies are going to die. I was told, I've been at this for 7 years, and I was told a story last week that in one of the developing countries, pregnant women lie about their pregnancy, and they don't disclose it until they have the birth and the baby survives because of the difficulties and not wanting to have to deal with the concern of their friends and families. Can you imagine that? You know, here in the first world, you know, we have parties and we have all kinds of things and we celebrate a birth, but in some parts of the world, you know, birth can be a deadly, deadly situation. Houston is fortunate that it has the largest medical center in the world. And with that medical center, Medical Bridges is able to tap huge quantities of medical equipment and supplies. In the last 3 years, we've shipped 700 tons of life-saving medical equipment supplies worth $34 million to countries around the world. And each of the countries, and the countries that have been represented here, with one exception, we have served recently. We have not been back to Gaza since before October 7th. And working with Sonali and International Medical Corps, we have staged 4 40-foot containers, specially wrapped, specially taken care of, because the rules, as Key pointed out, are so different that we can't use our routine methods. They're ready to go right now, and we're hoping that we can get the shipping taken care of before the month is out. So in the world, which is on fire, there is hope for people. And that hope comes from those of you who have participated. Thank you to all who spoke and all the panelists and those who paid attention, because with your support of any of these organizations, you can make a difference. 11 cents will buy a pair of gloves, which means somebody can get an operation, diagnostic, or procedure and not worry about an infection where, if there are drugs, they can die of the infection. So don't ever be overwhelmed by the need. Whatever can be done, it's volunteering, it's donating, it's sponsoring. These organizations will love whatever support that you might be able to offer to advance their mission. The final thoughts are just a tremendous gratefulness that I have to everybody who's joined us on World Health Day to talk about these issues. My enthusiasm for what Together we'll do on World Health Day next year, and my enthusiasm about how we'll be able to update all of you with some help from you about how much more we've done over the next 12 months. Special recognition to Sonali, who made this possible, and to Ambassador David Satterfield, who really made the connection to Sonali that is the birth of all that we've done today. Also my colleague Akini Adoyo, who opened it, and very much to Gidget Swift, who you don't see, but has been behind the scenes and made this, for Medical Bridges, fairly complex event, work really smoothly. Sonali, do you want to have a last word? I see you're still here.
I am here. I wouldn't miss the rest of the panels because I have all my friends, Aaron and Key and others, had to hear y'all. So just to say thanks. It's so great to be part of this community. Great to be with Medical Bridges. Yeah, let's hope for peace and advancement on global health and humanitarian issues. Last plug, please do come to our Baker Institution, Baker Center event with ICRC and MSF for a riveting discussion. It's on our website, but just shoot me an email if you need any more information. You're all very welcome, and thank you.
So with that, thanks to everybody who participated. I'll piggyback on Sonali. May all of you and all of the people of the world have peace, have health, and have the opportunity to thrive. Thanks so much. Have a great evening. Bye-bye for now.